Hello, 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 my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, November 9th, 2025. I apologize for being a few minutes late. It is what it is. Technology is never as easy as it should be. My purpose in doing our support group meetings is to make people more knowledgeable, informed. I want to open some new doors. I want to give you hope. I want to give you comfort. I want to give you as much as I can to show you that you're not alone in your struggles with IC. You're not alone in your suffering, because I know some of you are genuinely suffering, and that there is hope. And for anybody who's been told you have an incurable bladder disease, I'm telling you right now that that actually could be wrong. That many IC patients do not have a bladder disease at all. For many of us, it's a neuromuscular issue. And so one of my personal causes is I want to find patients who have been told that there was no hope, because there is always hope. We have learned so much about IC now. And now that we have phenotyping, now that we understand distinct patient groups, now that we have a better way of matching the right treatment to each patient, things are getting a lot better, my friends, a lot better. Now, I would really appreciate it if you guys could do me a sound check and just let me know, is the sound okay? It should be okay for YouTube. Please tell me. We are streaming right now on Facebook and YouTube. And I just want to see how we are doing. Hello, Gay. Nice to see you, hon. Hope you're having a good day. It's a gorgeous day here in California. I love these, I love the fall. I love the air. I love the golden sunlight. I love the colors on the trees. But, change is inevitable and it gets colder. And the funny thing here is that I don't know why, but our sun has gotten so bright you can barely walk out in the sun. It's like being on the top of a mountain in snow country on a bright, clear day. You're like walking out with your eyes all squinted because the sun is so bright. I totally strain my eyes. All right, so YouTube, my friends, if you could, hello, Sandra. Sandra says we are good on YouTube also. Oh, hello, Paige. Hello, Tana. I'm so glad that you're here. I am happy to take any and all questions that you might have about IC. Ann says, I use topical estrogen for a month, had burning. The estrogen had me stop it to find out if I had a yeast infection. Thus, I'm getting flares, one day good, one day bad, burning. And the frequency, is this a vulvodynia flare? Honey, you got to give me more information than that. So understand that if your skin is very, very dry, if you are in estrogen atrophy, significant estrogen atrophy, anything you put on that skin is going to burn at first. It would be really rare that it didn't, unless it was something like vulva balm or coconut oil. But any basic kind of medication that you might want to put on your skin, very, very good chance that estrogen is going to hurt at first. But every subsequent time you use it, that skin absorbs that estrogen and starts to produce mucus. And so slowly over time, over a couple of weeks, the burning should go away. Now, some patients do not understand that. And so when they start to feel that burning, they go, oh my God, it's hurting me. And they stop, which is a really bad mistake, because your skin is just going to get drier and drier and drier and drier. And I have a family member, this happened to a family member who literally, I'm like, girl, you need to be using your estrogen, because she's a few years older than me. And she's like, oh no, I'm going to go naturally. I'm going to cold turkey it. And I'm like, You're going to pay a price. And like a year or two later, she finally cried uncle and said, okay. Clearly I'm very, very dry and very, very uncomfortable down there. So she got the estrogen, and the estrogen burned her badly because she had allowed her skin to get drier by another year. Oh, wait, why am I wearing my earbuds? Okay. And so it took a longer, I warned her, I said, this is going to happen. Do not freak out if this happens. That's going to go away with time. You just have to try to build your skin up again. And it did. Anne says, a vaginal atrophy flare. You stop the estrogen, you're a gynecologist, took a swab, you have a yeast infection now. You're getting flares, one good day, one bad day. What flare is the burning and frequency? It can be both, hun. But one of the reasons why you would be more vulnerable to a fungal infection is because your skin is so dry, and basically bacteria and fungus can basically swim up to the cells of your skin and infect them. So cause and effect. The effect is the infection. So what's the underlying cause of the infection? The fact that you're older and your skin is atrophying and it cannot defend itself as well. Okay, here, hold on one sec. There you go. Okay, so literally, as I was getting ready to do this meeting, we got an email from the international IC world distributing a brand new fact sheet on ketamine cystitis. And I thought, you know what, this is a really good opportunity, and hold that thought, to talk about this for a moment. So the bladder, like any other part of the body, can be injured. There's no doubt about that. It is not made of Teflon. It is not made of steel. It is, in essence, vulnerable tissue. And generally, the way the bladder gets irritated is through a toxic chemical exposure. So, for example, those patients who develop IC symptoms while they're going through chemotherapy, the chemicals in chemo are well known to be quite irritating to the bladder wall. So it's very common for patients going through any type of chemotherapy, whether it's for breast cancer, uterine cancer, pancreatic cancer, prostate cancer, there's a very good chance that while they're going through chemo, they're going to start suffering from some urinary symptoms. They're going to have to go more frequently, and they might have some pain. Thankfully, there is one medication that they can take called Mesnex, Mesnex, that can greatly reduce the effect of that chemical. The second thing we're going to look for, seriously, you got to remember the human body is designed for water. Okay? It is not designed for soda all day. And there are patients out there who refuse to drink water. All they want to do is drink soda. The problem is that if you do that consistently every day over time, can your bladder heal itself or protect itself from that consistent, persistent chemical irritation? And the answer is eventually it's going to take a toll. And so if you started drinking sodas when you were 14 and now you're 35 and you've been drinking soda for 20 years, then God forbid you be drinking a lot of diet soda, which has the extra added formaldehyde and irritants that come from NutraSweet, aspartame, the artificial sweeteners. That's like a double, triple acid that's going through your bladder all day long. And again, eventually it's going to take a toll. Eventually the bladder is going to break down. I mean, if you poured acid on your hand every single day, what do you think is going to happen over time? I mean, you might be good for 3 months, but eventually that hand's going to start to turn red where you put the acid. Eventually, if you keep doing it, you're going to get redder and redder. And then eventually you might have a blister or a wound. Eventually that wound might start to bleed. And God forbid you have a wound on your hand and you're continuing to pour acid in it. That wound is just going to get bigger and bigger and bigger. So it's very, very, very common for people who have drunk a lot of soda and a lot of diet soda and or a lot of coffee, or more recently, I was reading a case study of a person who drank green tea for 30 years. And green tea is profoundly acidic and irritating. Okay, so you have to remember that when our bodies were designed a million years ago or whatever, we didn't have soda, we only had water. And we are over 95% water. You have to understand that our body needs water to be healthy, not soda. The third thing we're going to look at is what I want to talk very specifically about today, and this is called ketamine cystitis. So ketamine is an anesthetic used in animal hospitals. So if you've ever had a cat or a dog who've had to go get fixed or have some sort of procedure, the odds are when you pick them up, they're kind of kind of loopy, kind of spinning, kind of walking in circles. That's ketamine. Ketamine causes what we call dissociative high. And so you kind of feel like you're floating in space. It's not physically addictive, but it is psychologically addictive. So basically, what has happened in the last 20 years is that ketamine went from just being an animal anesthetic to being a recreational drug. And I will say also in humans, it has been long used for end-of-life care. So if you've got somebody who is dying and who's in a lot of pain, of course they want to treat that pain. They don't want that patient to suffer. Ketamine has commonly been used in end-of-life care, where we're not worried about the bladder being, destroyed over time. I mean, you're talking the last 2 weeks or the last month of that patient's life. Here's the issue. Ketamine has now become a massive recreational drug, and its use is increasing around the world. We first documented it, I want to say like in 2006. I think it was a study from Canada where they started seeing more and more young people coming in with urinary symptoms. And they didn't have infection. But when they looked at their bladder and their urinary tract was profoundly damaged. And the connection is they had all started using ketamine at parties. Ketamine is often cut into ecstasy. It is often sold pocket to pocket at parties through teens and 20s and 30s. The first ketamine patient I worked with was actually a fairly famous Hollywood producer. And I knew who he was. He knew who I was. I'm not going to share his name. Actually, I honestly don't even remember his name because he wasn't like top tier. He was lower level, although I didn't know of him. And he had been bleeding from his bladder. He couldn't sleep. He was up all night. It was affecting his ability to work, very, very sleep deprived. And he didn't really quite understand it at first. I mean, he was thinking it was infection, yada, yada, yada. And then finally the light bulb turned on. And he realized that when he used ketamine at a party, he bled that night. So he made that connection. Using ketamine damaged his bladder. He couldn't stop. And I said, well, where are you getting it? I mean, like, how did this even become a part of your day? And he said, oh, we just drive down to Mexico and grab it at a vet hospital. Oh, and I was just like, that's heartbreaking, because in the end, he had to go into extensive rehab to try to kick that addiction. I have worked with many ketamine. I think we're the only group in the world that does ketamine support, as far as I know. I don't know of any other groups that are doing direct ketamine support like we are, although they're starting to talk about it a lot more. I have a website called ketaminecystitis.org where we have a lot of the latest research. Ketamine acts as an industrial solvent. It is horrifically damaging to tissue. It is damaging to the kidneys. It's damaging to the ureters. It's quite damaging to the bladder. And if you keep using it, you will destroy your bladder. We have no direct treatments for ketamine. Ketamine is the equivalent of just for putting something very, very toxic inside your body and directly on the bladder. And the first and most important treatment is to stop doing that. If you stop doing that, you're giving your bladder a chance to heal. If you keep doing that, you're going to badly damage your bladder more and more and more until eventually the only treatment is bladder removal. And we have patients right now around the world who are having their bladders removed, and literally they refuse to give it up. They're so addicted. I can remember there was a case study in Germany of a young man, and I think he was like in his late 20s, who his bladder was so profoundly damaged. They just said, listen, you have a choice. We either take your bladder out or you stop the ketamine. And he said, well, I'm not giving up the ketamine, so you can take out my bladder. Not understanding the devastating consequence to that, because having your bladder removed is obviously a very, very severe procedure. There was also a study years ago done by the British Society of Urologists, BAUS, the British Association of Urologic something, where they surveyed every single urologist in the United Kingdom to see if they were treating ketamine cystitis. And you know what? Every single one was. That's how big it is in the United Kingdom and in Europe. It is also very, very big in Asia because it's cheaper than heroin. So ketamine has replaced heroin on the streets. And so I was trying to help a woman who was trying to start a new national organization for IC in Thailand. And she had her first meeting, and it was filled with ketamine addicts. Like there was like one typical IC patient, and there were like 40 ketamine addicts. In the United States, we have a real significant barrier here. The barrier is that our urologists don't ask about it. And so what I always say is, listen, if you're treating a teenager or 20-something with sudden onset urinary symptoms, and especially if they have a lot of blood in their urine, like question number one is, do you use ketamine? Have you used ketamine? So we do not have, as far as I know, any sort of study in the United States that shows how common it is. I've worked with addicts across the country using it. I know that the Drug Enforcement, DEA, has tracked ketamine from pretty much every major drug group. It's coming up from Mexico and from Latin America, and it's also coming from China and Asia. So I need you to understand here that your IC journey is all about creating an environment that will help your body heal. And if you happen to have the bladder wall phenotype or the Hunner's lesion phenotype, but really any of you, the single most important thing you got to understand is chemical exposures matter. Chemical exposures can hurt. And this is why we want to step away from the strong irritants, whether it be the Diet Coke, whether it be the Mountain Dew. Of course, if you've got cancer, you got to do the chemo because we absolutely want to save your life, but that's going to be a journey during that chemo. And I'm here to help you. We're here to help you if you need help to kind of get you through that process. So that's my little blurb on ketamine. If anybody knows anybody out there who's struggling with a younger person who is struggling with urinary symptoms, please ask them about that. Send them over to our website, ketaminecystitis.org. So what are we going to do for somebody with ketamine cystitis? Well, let's say, okay, you're going to stop the ketamine. Praise God. Hallelujah. Thank you for stopping the ketamine. Whoops. Hold on a sec. Okay. The ketamine cystitis patient is treated very similar to the IC patient. Okay, so we're going to be following that diet to protect the bladder wall. We're going to be trying maybe some medications like Myrbetriq to reduce some of that neuroinflammation, that frequency urgency. That's going to be really important. They might benefit from some of the supplements that might calm and soothe their bladder, like Allopath. And ultimately something that can try to coat and cover their bladder while it's healing. They might be given a low-dose antidepressant to just try to calm some of those nerves down. They certainly would be good candidates for bladder installations, especially heparin lidocaine installations, because that's going to numb the bladder, coat the bladder, and protect the bladder. And so we're going to send them through our typical IC treatment protocol. All righty. Okay, so that's my little blurb for the day. The other thing that I was thinking I was going to talk about was getting ready for the holidays a little bit, getting ready for Thanksgiving, which is in 2 weeks. I do want you to know that I am not going to have a meeting next week because it is my sister's birthday and I'm going to be with her. She's asked me specifically to come, so I'm going to come because I adore my sister. I mean, she stopped her life and moved in with me for 2 months during my breast cancer. So I can skip a meeting. So our meeting after that will be the meeting before Thanksgiving. But before we get there, this is like just totally good news here. And that is that for Americans who are celebrating Thanksgiving, a typical Thanksgiving Day meal is perfectly bladder friendly. Turkey is fine. Just don't, I just would not do, I wouldn't do a salted cured turkey, or, what do they call it? Oh, come on. A salt rub or scrub. Oh, come on. What is that word? It'll come to me. We just want a simple roasted turkey. Put butter on it. You're good to go. Stuffing for the most part should be absolutely fine. Mashed potatoes, fine. Sweet potatoes, fine. Pumpkin pie, fine. If you can back off a little bit, maybe on the cinnamon, that's fine. If you're making it on your own. The blessing here is that now that we're in fall and now that we're in the holiday season, the diet gets a lot easier. Unless, of course, you're going to grandma's house and she's making lasagna, which was one of my challenges. One of my challenges was we always had lasagna on Christmas Eve. And oh my God, did I have terrible flares from that. Remember too, this is the time to stock up on pre-leaf, because pre-leaf will reduce the acid in any risk foods that you might be eating. And so making sure that if you're going to grandma's house or you're going to somewhere else, you can do some pre-leaf. Pre-leaf also works if you want to try to have some wine with dinner. It will take the acid out of some of that wine, although not the alcohol. I would encourage you to try a de-alcoholized wine, which is what I've been drinking. I'm not drinking alcohol right now at all as a cancer patient. I'm not interested in it. A lot of the new research shows that alcohol is widely toxic throughout the body. And I just don't want to go down this pathway that I've been for the last couple of years. So I'm doing everything that I can to protect my body. Low salt, low sugar, no alcohol. Because I just want to heal after a 2-year cancer struggle. So try the de-alcoholized wine. Like the one brand is Free, F-R-E. You can throw some pre-leaf in there, and I bet you'll be able to get away with that. The hardest part about the holidays is just trying to decide if you're going to go or not. Now, I will tell you, my mother was a master at guilt. Bless her soul. Mom, you know exactly what I mean. She couldn't stand the idea of any of her children being alone on a holiday. And if I was having the worst flare ever, she would still call me and talk to me and say, honey, we're going to come pick you up. Honey, we need you to come, yada, yada, yada. And I went to some holidays, just a wreck. And I remember thinking there was one Christmas in particular where I had no pain meds. I was in so much pain that I was nauseous. I could barely walk. And I got to my sister's house. We were all celebrating. And I just went up into her bedroom and I laid in bed for hours. And I ruined their holiday because everybody was like going, what's wrong with Jill? What's wrong with Jill? And I hate that. I hate when people talk about me like that. It's like, I'm having a flare. Just leave me alone, right? You know, I don't know why. That's how I felt 25 years ago when I was going through the worst. And then, you know, she convinced me to drive 2 hours to my brother's house in a terrible flare. And I got there and I was a wreck and I had to drive home in a terrible flare. And finally the light bulb turned on. And finally I went, now wait a second. This never goes well for you, Jill. It is okay for you to stay home. And I put my foot down. Now listen, if you're feeling good, for God's sake, go. If you're, you know, if you're at a 6, 7, if you're at a 1, 2, 3, 4 out of 10, go enjoy yourself, be with your family. But if your symptoms are at the point where you don't want to move a lot, where you're worried that the drive is going to trigger a terrible flare, which certainly can do. Hello, Johanna. Hello, Boria. This is when you get to say, guys, this is not going to happen for me today. Now, of course, you can always be proactive and just say, hey, listen, I don't know if you know this or not, but I'm having some health challenges right now, and it is really hard for me to get in a car. And so what I'd love to do is have you guys come to my house. And we're going to do a potluck. Everybody bring their favorite foods. Come on over. Let's just have a ball. And this is going to be easier for me. That is a great, great solution. But if your tradition is going to grandma's house and that's an hour drive and you're in a flare, that might not be viable for you. You have the right to say, I'm going to stay home, but you can bring me some leftovers. And my mother would be like, are you sure? Are you sure? We really want you to come. Are you sure, Jill? And I'm like, yes. And I remember I have 2 very, very specific memories. Memory number 1 was over either Thanksgiving or Christmas, and I was just in agony. And I said no. And she worked me for about 10 minutes. She tried everything she could to get me to go. And I just said, no, I'm staying home with my heating pad. And I won. And as they drove away, I bawled my eyes out because I didn't want to be alone on a holiday. But I also knew I needed to stay home. And I completely remember I turned on a new movie that I hadn't seen, and I had my hot water and my chamomile tea, and I had my heating pad, man, and I just chilled. And then 4 hours later, they came back with turkey leftovers, and we were good. I survived. They survived. We were good. It is hard to stand up for yourself. It is hard to disappoint others. It is. But you get to come first. You get to come first. And so I want you, so what I did is I finally kind of got to the point where now my family knew there was a good chance that Jill would say no, and there was a good chance that Jill would say yes. But the guilt was overwhelming. And it was making me anxious and upset because people were asking, Jill, are you going to come a week before? And are you going to come 2 days before? And then the night before they'd call me, are you going to come? And I'd go, I don't know, honey. I don't know. I have to wait and see how I sleep that night and how I feel the next morning. And it just became upsetting and dramatic, and everybody was mad at me because I was disappointing them. And so what I just finally said is, listen, guys, I'm taking all the emotion out of this. I'm not going to think about it. I'm not going to worry about it. I'm just going to wait and see how I feel that morning. And if I feel good, I will be there. And if I don't feel good, I will be staying home with my lover, the heating pad. And that was a very, very, very helpful for me. Now, the other really strong memory I had was when my cousin Sissy got married, and it was in Southern California. It was a plane flight. And I was supposed to be in her wedding. I was speaking in her wedding and had absolutely the worst flare ever. And there was just no way I was even going to get to the airport. I would have had to have been fully anesthetized to get to the airport and take a plane flight. And so I called Sissy and I said, honey, I'm really sorry. I just feel terrible. And my sister filled in for me. So my parents and my sister went down to the wedding. And again, they drove away and I cried for a couple of hours because I really, really, really wanted to be there and be in that wedding. And because I haven't had, that was like one of the first invitations I've ever had to speak at a wedding. And anyway, I cried. I cleaned the house for like 2 days. The house was immaculate. And then I made apple pies. That's all I remember is I made like a bunch of apple pies from an apple tree in the backyard. And then they got home. And the first thing they said is, oh my God, Jill, you made exactly the right decision. And I'm like, why? And they went, because we were all dying, because we had to go miles down this very bumpy country road to get to this old church they were using. And they said it was agony for them. They struggled. And they said, if you had tried to come, it would have been horrific for you. So you made the right decision to stay home. And I'm like, okay, phew, praise God. So again, you get to come first. We have a lot of articles on the holidays and getting through different, how to deal with the stress of the holidays, food for the holidays, all that sort of stuff. Also, our next IC Optimist is going to be our Winter Optimist. I'm going to try to have done the second week of December, maybe the first week of December, if I can get to it quickly. It's going to be dedicated entirely to how can I see patients manage getting through holidays and vacations and things like that, because, it's hard. And, God forbid you be on your honeymoon. That's really tricky. But there is always workarounds. And we always want to give you hope and comfort and show you that you can do it. You can do it. Okay, so I am here as long as you have questions. Obviously, I can talk forever about a lot of different things. I am happy to share my knowledge with you. I'm happy to share any resources with you that I have, but you have to give me questions, or what I can do is put on some videos and things like that. So Holly says she is in the worst flare up ever. Holly, what do you think triggered that flare, hon? What do you think triggered that flare? Was it something? And when did the flare begin? Anne says, your yeast is gone. You took diflucan, going to the urogynecologist on Wednesday, getting flares, one good day, one bad day. What flare is this burning in frequency? Honey, I don't know. I mean, you could have a candida infection in your vagina. You could have a candida infection in your bladder. We now know that yeast infections can happen in the bladder. And it was our own National Institutes of Health who made that discovery. And what they found too is the more candida you have, the greater the pain you're going to experience. The other thing we know, honey, is that 1 or 2 diflucans will not kill very, very difficult infections. And if you look at the drug information sheet for diflucan, down at the bottom, there's this little section that says severe infections may not respond to 1 or 2 pills. Severe infections might need an extended course of treatment. And that was certainly true for me when I had my my wicked yeast infection years ago. Okay, here, hold on a second. By the way, just fair warning, I'm cutting my hair off on Wednesday. It's going. I'm sick of it. All right. Johanna said, I have been going to pelvic physical therapy, but she keeps sending exercises for home, breathing and stretching, but she's not done any work inside. I don't know what to do. I sent her a message asking for her to work inside. That's a priority. She has not responded. Well, what is she doing when you go to physical therapy? Like, what is she doing? And Holly, tell us what do you think triggered this flare? Mayor says that is, yeah, it is odd. It is odd. The best physical therapy is hands-on physical therapy. That is a finger in your vagina, or for a gentleman in their rectum, directly massaging muscles. Let me get my model. Hold on a second. All right. I have to take out the bits. Whoops. Okay. So let us, for a moment, talk about the pelvic floor. So this is your pelvis. We've got a hip bone and hip bone. And if we look at it from the back, we have your spine, your vertebrae, right? We've got your sacrum. What's so interesting about the sacrum is that these are what we call vestigial vertebrae. These were also vertebrae that basically fused together. So your spinal cord comes down through your spine, then it comes here, and you see where these holes are? The nerves go through these holes into your pelvis. Now, if we look further, hello, tailbone. Here's your tailbone. And if you look at it from the side, you will see that the tailbone curves under. So think about when you're walking your dog, or if you have a cat and they're just chilling, they're just happy, their tail is hanging down and the tip is curled between their legs, right? That is the normal, natural position for the tailbone. The other thing you've really got to understand about the pelvis is the tailbone just doesn't hang there and do nothing. Look at everything that attaches to the tailbone. Look at the muscles. The tailbone helps you balance. The tailbone helps you walk. Our human tailbone adjusts subtly all day to compensate for however we're moving our body. Okay, now let's look at it from the front here. So now from the front, we've got the pubic bones and the pubic symphysis. These are the symphysis basically holds these bones together. And if we look at it from the bottom, you will notice that there's no protection. There's no protection here. And I'm going to put on the most shallow muscles, which are your levator muscles. And yes, I'm part of my levator broke. But here are your levator muscles. You basically have 3 levels of muscles. And they're kind of this, think about the knuckles on your index finger. So you've got shallow, mid-level, and deep muscles, okay? So these are the shallowest muscles, and then there are mid-level muscles, and then there are deeper muscles. Now, if we look at it from the top, the other thing that's really important here is that, you know, the pelvic floor is kind of like a woven basket of muscles. They go from left to right, front to back, low to high. But they sit along the base. They're supportive. So you can see here that they're sitting along the base of the pelvic cavity. Now, unfortunately, what happens is when these muscles get tight, they lift up. They come up off of the base and they start interfering with other structures, and that's not good. I'm trying to think, okay, how can I show that? Oh, this is a good way to show it. Okay, so here's flat, relaxed, healthy. Here's tight. So there's more tension on the muscle, so the muscle goes up into the body of the pelvic cavity where it has the potential of interfering with more things like nerves and blood vessels and things like that. So the best way to get these muscles back into their proper position is to stroke them and rub them, just like I'm doing here. This is exactly what a physical therapist would do with their finger. They're going to now understand that a tight muscle feels like beef jerky, or a very, very, very tight muscle. Even a damaged muscle is going to feel like beef jerky. A tighter muscle is going to feel like a cooked chicken breast. A healthy muscle is going to feel like a raw chicken breast. It's soft, but it has substance. So as soon as they put their finger inside of you, they're going to know instantaneously the health of your muscles, just like you would know instantaneously the health of your muscle. And generally what they do then is they try to follow the muscle group. They will be able to tell very quickly which muscle it is. They know the position of that muscle. They know the length of that muscle. And usually they will follow the length of that muscle with their finger and get that muscle to relax and release. It usually just takes a minute or two. And if you had a wand, so if you had a wand, here, hold on a sec. Let me open this up. So here's a wand. And so many physical therapists will teach you, and the goal is for you to be independent. So you're not depending upon a physical therapist. They will teach you how to use a wand so that you can get in there yourself and try to get these muscles to relax and release. That's what I do. In fact, I'm very close to needing to do it again. I was at the gym today and I did a very fast 2 miles on the treadmill and I lifted weights and I started feeling pain around my rectum, the muscles there, which tells me that my muscles are starting to get tight. And so you can see here, the best way to assess the health of these muscles is by touching the muscle. And a physical therapist who doesn't touch the muscle is, in my opinion, not following their training. Hands-on physical therapy is usually the best way to do this. And I can only assume that they're just uncomfortable with it or they haven't had the proper training. They haven't had the classes to do it. Now, let me just describe a little bit about what I do, because, you know, I have like no shame and I will talk about pretty much anything. I drop trowel, lay on my bed on a towel, and I put my feet up on the wall. That is my position for doing my internal massage. And I've got my wand, a little bit of KY. Obviously, things are very, very clean. And I insert it. And all I'm doing is looking for tender spots. I start on one side, and I know what healthy muscle feels like because I've done it so many times. Guys, please understand that I am the pelvic floor phenotype. My bladder has always been perfectly healthy every time they've looked at it, even though I had such severe bladder pain that I thought I was dying of cancer. I didn't. I always had a healthy bladder. What I didn't have was healthy muscles because my symptoms started when I broke my tailbone. And when I broke my tailbone, I hurt those muscles. Okay, so again, a healthy muscle is soft, pliant. It's got firmness, but it's pliable. A tight muscle is tender and uncomfortable. And so, as I'm laying here, I will start on one side with my wand, and I will just slide it shallowly, mid-level, deep. And all I'm doing is looking for tension or looking for tender points. And if I find it, this is what I do, pretty much. This is what I do. If I find a trigger point, I might press on that trigger point. Sometimes I strum the muscle like this instead of going lengthwise. I will work on one side and then I go to the other side. One and done in 5 minutes. My first warning sign of tight pelvic floor muscles is pain around my rectum, which I had this morning at the gym. And that makes sense when you consider the levator ani muscles, which are your shallow muscles, which wrap around the rectum, wrap around the vagina, and wrap around the urethra. And if these muscles are tight, what do? They start to squeeze and cause discomfort. And so when I start feeling pelvic pain and rectal pain, it is always right here in this muscle group, or sometimes it's here. That's where my tension is. And sometimes, so here's your sit bones, right? I've always had a lot of tenderness around my sit bones. And I can remember 30, 40 years ago, my doctors would have me roll on tennis balls because they were so tight. I was a professional tennis player. I was a collegiate tennis player, and then I played pro for about a year before I decided I wasn't good enough. And I had a lot of muscle stuff going on there. I used to eat Advil like nobody's business. It was so bad. I was such an idiot. Okay, so anyway, a lot of residual tension around sit bones. I was working with a guy this week who he said he had a lot of tension here, and he had a lot of tension like on the far, like around his left hip. And I'm like, well, you do realize that's not your bladder. And he's like, what? And I went, your bladder isn't over there. That's your pelvic floor. And he was like, whoa. I didn't really understand that. And sent him off to have a pelvic floor examination. He also had an old injury. We now believe that 90 to 95% of the guys diagnosed with interstitial cystitis are pelvic floor driven, usually from an old injury. And so again, in my case, this is what I broke. I broke the tip of my tailbone off when I was 13. And I can remember I could move it for a year. I would just stick my finger down there and just move it around. I was a kid. I didn't know any better. And so basically, all the muscles that attach to that tailbone got profoundly injured and damaged. And so 30 years later, okay, so just to kind of give you a clue, broke my tailbone. Couple months later, couldn't, whoops. Hold on. Okay. Anybody wants to know what that is? That's Greta Van Fleet on my cell phone. I like Greta Van Fleet, a rock band from Michigan. All right. Okay. So here I break my tailbone in the summer. And I go to school that fall, and I couldn't sit through class. And the teachers complained. They got quite annoyed with me as I kept saying, Mr. Rydell, I really need to go to the bathroom. And they're like, Jill, you just went. I'm like, I'm sorry, I need to go again. Called the nurse, called my parents, got my mother all upset, took me to the doctor. The doctor said, well, she must have a bladder infection. They gave me a massive amount of antibiotics, even though the testing was negative. And I still remember I had a hydrodistension with cystoscopy at the age of 13. And I also had a kidney exam at the age of 13. What I had was something called a urethral stricture. My urethra was very, very tight. It was so tight that I couldn't pee through it. And so what they did was something called urethral dilations. They basically stuck a piece of metal up inside my urethra and jammed it open. At no point did anybody ever say, gee, why is your urethra so tight? Becky says here, oh my God, I broke my tailbone at the same age. I battled IC pelvic floor dysfunction ever since. I'm 55. Becky, you are my sister. Classic, classic. So the question is, Becky, when you went to pelvic floor, what did they find? So, of course, back then, we were all told that we had an incurable bladder disease. Even though they looked at our bladder was fine. My bladder has always been fine. Yeah, my urethra was damn tight. And again, as I said, nobody ever said, gee, why is it tight? Well, hello, she broke the damn tailbone, which stressed the muscle, which made the muscle tight. I had severe vulvodynia in high school, and my vulvodynia was concentrated right here, the perineum. This was my hot spot. It felt like somebody had taken sandpaper and scrubbed my skin off right there. It was so tender that I would come home from school and I would sit in the bathtub for an hour, which was crazy. So why is this meaningful? Because directly underneath the skin of the perineum, hello, is a muscle group and something called the perineal body, which is an attachment point for 4 muscles. So anybody with perineal pain, odds are they're having muscle pain directly underneath that. Then I had irritable bowel in my early 20s. Then I had TMJ. Then I had migraines. And then for the first time, I had bladder pain when I was 32. And again, normal, healthy bladder. We didn't know about the muscles back then. The muscle research came out in like the late 1990s, mid 2000s. And I went, oh, well, let's go get my muscles checked. My muscles were as hard as concrete. My muscles were in horrific shape. But guess what? Muscles respond beautifully to physical therapy. Muscles, it doesn't matter how old you are. You could be 95 years old and get pelvic floor physical therapy, and it would help. Muscles respond beautifully to muscle work. You just have to use them. You have to retrain them. You have to touch them. And so once we found the underlying cause for my symptoms, which was an injured pelvic floor, now we understood why bladder treatments never worked for me, because they never did. But pelvic floor physical therapy worked tremendously for me, and it still works for me. And now I can do it at home, and I know what to do. Liz says, my IC was totally bladder centric. It was so destructive to my bladder wall. I wish there were groups for people who have IC like I had. Before my surgery, I felt lost because there was so much talk about the pelvic floor that is nothing like what I had. It seems like a totally different issue. Mine was a disease. So Liz, you're just a different phenotype. You got to understand, interstitial cystitis is what we call a grab bag diagnosis. Basically, what that means is you have frequency urgency pain and they don't know why. So they go, oh, you must have interstitial cystitis. And back then, we were all told we had an incurable bladder disease. But here's what we've learned. We've also learned that bladder treatments don't work for most of us. Why? Because there are different types of patients. And if you were to come to a physical meeting, that's one of the things you'd see really quickly. For some people, IC begins in childhood. For others, it begins after menopause. Same diagnosis, but are we the same? No. For some people, IC begins while they're going through chemotherapy, while for others, IC begins when they fall down the stairs. Or if they have a very, very difficult childbirth. Again, same diagnosis, interstitial cystitis, but are we the same? No, we are not. We are not the same. And so today we respect that. And we use something called phenotyping to figure out what group you're in. So you are in the bladder wall or Hunner's lesion group, 100%. And I'm sorry that you're there. You're not alone. 3 to 8 million women, 1 to 4 million men in the United States alone have this. And if we were to put a number on it, 5% of patients have Hunner's lesions, 5 to 10%. The bladder-centric group is probably maybe 15 to 20%. So 15 to 20% of, 8 million people, man, that's a lot of people. That's over 1 million people. So you are absolutely not alone. So the question now is, what was happening to your bladder? Was it a disease? Was it, we now know that some patients have profound viral infections in their bladder. We know some patients have profound fungal infections in their bladder. We know that there's a small group of patients who have an autoimmune disorder. So if you've got Sjogren's, lupus, and you're having bladder symptoms, that's something that we're going to look at. Those are the patients who might benefit from cyclosporin. You are truly an anatomical mystery to be solved. I give you a really, really good example. And we talked about this last week. I had a mother who had a young daughter who was probably 12, 13 years old, diagnosed first with interstitial cystitis. She couldn't go to school. She was really, really struggling. Terrible urinary symptoms, up all night. And when they finally went in and they did a biopsy, what they found actually is that she had something called eosinophilic cystitis. An eosinophil, eosinophil, eosinophilic cystitis. Eosinophilic cystitis is characterized by a bladder wall filled with eosinophils, white blood cells. It is like the human body has mobilized this giant immune response and flooded the bladder wall with white blood cells to kill something, because that's what white blood cells do. Normally they hunt and kill, bad things. So, but in her case, they never found infection. So it's like, why is the immune system responding to such a great degree? And it turned out that it was contaminated well water, that it was actually her bladder's response to a toxin. And so, mom and I were calling and I went, all right, what's your water source? She goes, a well. I'm like, okay, so are you in deep farm? She was in farming country, but I'm trying to remember, was she like near a coal mine or something like that? And I said, you know what, just out of an abundance of caution, you need to get your water checked. And she did. And her water was contaminated. And I actually think it was like a chemical residue from a nearby property. So once they got the daughter away from the chemical exposures and they all stopped drinking it, things improved dramatically. And then we had another really, really interesting case. This was right before COVID, of a woman who also had been diagnosed with interstitial cystitis, really, really severe IC, really struggling. But what made her case so interesting is that everybody in her family was sick, but they all had kind of different things. So she was having bladder pain. Somebody else, I think, might have been having migraines, whatever. Everybody in the family was struggling physically, parents and children. And they found that their water heater had been leaking into the foam underneath their carpet. The entire house was carpeted. And this was a long-term leak underneath the carpet. And when they pulled the carpets back, black mold everywhere. Like it was one of the worst infestations ever. They had to immediately move out of the house. And it took a couple of months, but guess what? They all got better when they got away from the black mold. That black mold can trigger urinary symptoms. It's crazy. And, I got to say, when my parents passed away a year and a half ago, and I was cleaning their bedroom, which is now my room, I found black mold in a corner. Just, it was maybe like this big. And it was where they had, my mother loved small tables. Do not ask me why. So they had a bunch of small tables, and they had one that they kept putting comforters and sheets on that hadn't seen the light of day in quite a while. And I pulled it all away, and I found black mold on the wall, which I immediately cleaned with bleach. So, these bladder symptoms, you truly are an anatomical mystery to be solved. Anne says she has constipation. David says he does too. Hey, David, long time no see. So constipation is a well-known symptom of tight pelvic floor muscles. If your muscles are so tight and they're squeezing the bowel, it's gonna, whoops, there you go. If these muscles right here are tight, it's going to be hard to relax them to empty your bowels. Here, hold on a sec. My little thingy, my little microphone cover just popped off. All right. Hello, Camillo. She says, I was diagnosed with IC 3 months ago after cystoscopy, just mild frequency, no pain. Glomulations and mild inflammation was found. I joined a support group, but it seems to worsen over time. Based on the comments, I'm a little scared about the future. Is that for everybody? Absolutely not, honey. Absolutely not. I mean, here's what we know. You have glomulations, which means that, okay, let me take this a step back. So you have urinary symptoms that are unusual. Your doctor said, okay, we need to look at your bladder. They did what we call a hydrodistension with cystoscopy. A hydrodistension means they fill your bladder up with fluid, kind of stretch it out a little bit, and then drain it out. And they might do it twice, and then they take a look at the bladder. Okay? What happens when you stretch the bladder? Glomulations. Let me get a picture. So remember that the bladder is a hollow organ, like your stomach. So what's the most painful thing you can do to a hollow organ? Stretch it. Which is why they have you asleep. Because if you were awake and they were stretching your bladder, you would be in agony. So they always put you under anesthesia. There is a physical change that happens with a hydrodistension too. You're taking tissue and you're stretching it. So what that means then is we also have tissue trauma, which is why our national guideline, in the old days, they used to do what we call a high pressure, long duration hydrodistension. They would really stretch the bladder. They were thinking, okay, let's increase bladder capacity. So they really, really stretch it under pressure. And for what we call a long duration. So they put a lot of fluid in there and they leave it in there for several minutes. Man, just really tweaking the hell out of that tissue. And then drain it out and you're gone. And you're done. Of course, for those patients who had high pressure procedures, they would have terrible pain for, quite some time afterwards, because doing this is obviously going to stretch nerves, it's going to break tissue, all that sort of stuff. So our newest guidelines that started in 2008 say, no, we're not going to do that anymore. We respect and understand that a lot of patients have been traumatized by doing these aggressive procedures. Our number one goal now is to reduce trauma to the patient. And that's what our national guidelines from the American Urology Association say. And rule number one, or the first point they made, is that patients stop going back to urologists because the appointments hurt and the testing hurt. So they said, okay, no more high pressure. We're going to do low pressure, short duration hydrodistension. So instead of stretching the bladder like this, we're only going to stretch the bladder like this. Okay. And we're going to do it for a short period of time to minimize trauma. There are still urologists out there who are very macho and they go, no, I want to do it this much. And they ignore the guidelines. So glomurulations. These are glomurulations, okay? So when these were first discovered back in, when did we discover these? Like in the 40s or early 50s, okay? They all thought this was a disease. They thought, okay, this is IC. And in fact, in 1987, when the National Institutes created their first research criteria on who to add to research studies, they said, any patient who has glomurulations can be considered an IC patient and put into a study. Or the other thing we're going to look for is Hunner's lesions. So look at this. Now, this obviously is a big wound when compared to this. Very, very different. Okay. So again, they all thought, okay, this must be IC. Well, in 1987, when they did that, another researcher who happened to be a little bit more experienced said, no, guys, that's not IC. That's what happens when you stretch the bladder. And he proved it. He did a study of 50 women scheduled for tubal ligation, no urinary symptoms. He asked them if he could do a hydrodistension. Again, no urinary symptoms. This is what happened. This is what happened to their bladders. So if you were to look at our most recent guidelines for IC, these are thrown out. They now are guidelines that were just updated 2 years ago or 3 years ago, say the finding of glomurulations is meaningless to the IC patient because they are not unique to IC. They happen in other situations and when you stretch the bladder. Okay, so Camillo, the good thing here is that you don't have this. You don't have Hunner's lesions. This is great. This is great, great news. But your bladder's pissed off. Your bladder is inflamed. So we now have to figure out why. And this is where we do something called phenotyping. So I'm not sure how old you are, but really we're going to look for three basic things in a patient like you. The first thing we're going to look for is how old are you? Are we dealing with estrogen atrophy? Because if you're older and you're losing estrogen, that's going to change your bladder's ability to protect itself. Your bladder cannot make that nice thick mucus that normally protects the tissue. And so that cup of coffee you drink every day in your 40s, all of a sudden in your 50s hurts because you don't have a nice coating of mucus. So I would want to know, are you an estrogen atrophy patient? Number two, I want to know, are you a chemical injury patient? Are you drinking coffee every day? Are you drinking soda every day? Are you using ketamine? Is there something in your daily life that could be provoking and irritating your bladder wall? Your doctor has already done a workup for UTI. So the odds of it being UTI are low, even though there are a lot of people online saying everybody has recurring UTI. That is not true. We have the research to prove that. The IC patient has a normal biome. But we can have an overgrowth of fungal infection. And there are some other, variants in there. The other thing I would want to know for you, Camilo, is there any chance that you have an injured pelvic floor? Because when your muscles are tight, what do? They squeeze things, and they squeeze the blood supply. So if your bladder is supposed to get 24 units of blood a day, but if your muscles are so tight, it's only getting 12, are you going to have a healthy bladder wall? The answer, of course, is no. And so if your symptoms began after a pelvic trauma, pelvic injury, or how do we differentiate between bladder wall and pelvic floor, since they both cause the same symptoms? Both will cause frequency, urgency, pressure, pain. It's just very, very subtle differences there. Question number one is, when is your pain the worst? Before you pee or after you're done peeing? If your pain is the worst, as your bladder fills with urine and you feel better once you empty your bladder, that points to the bladder wall. But if your pain is worse, not before, but after you're done urinating, that points to pelvic floor. And of course, the most important symptom of somebody with tight pelvic floor muscles is, can you pee on command? Like, can you sit on the toilet and just let it rip? Can you pee like a horse? Or you have to hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine? Or are you doing a lot of stopping and starting? Or is your stream slow? That all points to muscles affecting the bladder. The flaw with online support groups is that you can't put apples, oranges, and bananas in the same group and expect them to help. Listen, I'm the lady who started the very first online groups. That was me. Like, I'm the fairy grandmother of the IC movement online. I started the first urology groups more than 30 years ago on America Online and CompuServe. I built the first website on IC. I built the first support forum on IC before social media. I've got over 100,000 patients who read my stuff. Okay. And I'm telling you right now, today, with what we know, online groups are not working. And the reason why they're not working is because of this diversity, because we're long past the day of telling everybody they have an incurable disease. For all you know, you are watching people who have Hunner's lesions. You don't have Hunner's lesions. They're on a different journey than you are. So I have had long conversations in the last couple of weeks with two of the support group leaders that worked with me in those early days, who are very, very experienced, some of the best, most knowledgeable dietitians and scientists. We are all deeply, deeply concerned about what we're seeing online right now in the online groups. And a lot of people have asked me, Jill, can you go help them understand what they're doing isn't working? They don't listen to me anymore. You remember, man, social media is all my way or the highway. There is a group online on Facebook that kicks men out because they do not believe men get IC. Just horrific. There's a group online right now on Facebook who says that they won't allow you to talk about anything other than the group leader's herbal approach. And if you try to talk about traditional therapies, you get kicked out. You know, back in those early days, remember, guys, I have a bunch of college degrees and I'm a researcher. I got a degree in chemistry. I got a degree in drug development. I have a master's degree in psychology. The IC Network was my doctoral dissertation for a doctorate in IC. I mean, in psychology. We had everybody trained. I trained everybody. That was my specialty when I was in grad school, was groups. I have a presidential fellowship. And so, and fundamental to all of that, when you're running a support group, is your opinion does not matter. You cannot allow your opinion to dominate a discussion to the point you turn somebody off from the one treatment that might work for them. And if we're doing an in-person meeting, listen, I play two roles. I'm an educator. So when I'm doing these meetings, I'm educating. I'm giving you a lot of information here. But if you were at a real meeting, like if we were on Zoom, it's not about me, it's about you and giving you an opportunity to talk and giving balance here. So I would just say to stay out of the online groups right now. We're just seeing a lot more harm than good happening here. And I don't know a single IC expert around the world who would support any group on Facebook right now. You know, and there are a couple of other groups out there that are just really marginal. And I've talked to some of the leaders and I'm like, guys, you got to at least talk about phenotyping. Everybody who comes to your meeting, they at least need to know about these different groups. Or everybody who comes to your group, they need to know that there are Hunner's lesion patients and pelvic floor patients and stuff so that they can differentiate and the information that they're receiving. Because somebody with Hunner's lesion should not be giving advice to somebody with pudendal neuralgia. And unfortunately, it scares a lot of people. And that's what we want to stop here. So I have very, very strong opinions on it because I'm the most, listen, I'm not patting myself on the back here. You just got to understand, I have the most depth of experience running groups online because I started the very first one and I've never stopped in 32 years. And the reason why I do these meetings, I mean, I stopped all of our meetings like 7 years ago. I was sick of it. I was sick of it. And I just didn't know what to do because there was just so much bad information. And finally somebody called me and said, I just need a support group, Jill. And I went, okay, I need to be a support group leader again, which is why I do these live meetings. Joni says, Jill, the only group I follow is you. Many thanks. And my symptoms were age-related, but still very sensitive urethra. Ah, yes. Yes, that little urethra can be remarkably uncomfortable. Remarkably uncomfortable. I mean, you want to make sure the tissue is as healthy as possible. So if you're not using your topical estrogen at the entrance to your urethra, talk to your doctor because that's normally what we do. That's what I do. The other thing we want to make sure is there any chemical that is irritating that skin. I will tell you, if I put on a pair of underwear wash and shear or Tide, I will have urethral and vulvar irritation usually within 5 or 10 minutes because my skin is very, very sensitive. So is there a chance that there's any sort of chemical exposure that's keeping your urethra on fire? It's possible. Camilla says, thank you so much. What you mentioned about the way I urinate makes complete sense. It must be related to pelvic floor issues. Everything you said matches what I feel. No pain, but irritation after urination. I really appreciate what you're doing. By the way, I'm 33. I've never had UTIs. I used to drink coffee occasionally, but I don't anymore. I don't drink alcohol, and I'm doing pelvic floor therapy right now. They found my pelvic floor muscles are very tight. There you go. Awesome. This is great. This is great, honey. God, I wish I could have been in physical therapy when I was your age. You know, the pelvic ischemia is real. Muscles that are tight cause a lot of long-term problems over time. And you realize my muscles were tight from the age of 13 until the age of 50. And when I think about all those flares that I had when I was traveling and driving and how that limited my life and that limited my ability to enjoy vacation and do normal things, all because I had a muscle problem. And then, of course, the thousands of dollars and it's spent on treatments, and most importantly, antibiotics after antibiotics after antibiotics that didn't have a bad chance in hell of helping me. This is why today is so promising now, because we know how to do a diagnostic workup. We know what the phenotypes are, and we know what the best treatments are for each phenotype. So it's a different world now. And I'm so incredibly glad that you're doing physical therapy. And, and a lot of people would say to me, because, we take phone calls all week, is, well, should I do anything else? Or the doctor says, well, let's do some Botox, or let's do this, or let's do some neuromodulation, or let's do Elmeron, or whatever. And your answer is going to be, how is that going to help my tight muscle? Because in the end, we have to treat underlying causation. And I would bet you at some point in time, you sustained a pelvic injury. Whether you were doing gymnastics, riding a bike, riding a horse, if you were sexually abused in any sort of way, there may have been trauma early on that created the foundation for this. And so if you only have $100 a month available to pay for treatment, for God's sake, don't throw it at a supplement that somebody's saying. You read a story online from somebody who's saying, do aloe, it helped me. There isn't a single published study that shows that aloe is helpful. Okay? In contrast, so what we need to do instead is we got to follow the data here. What does the data say? Well, the data says you have tight pelvic floor muscles, so you need to spend that money on physical therapy and getting a wand so that you can learn this yourself, I mean, I'm so much more hopeful than I was 20 years ago. All right, let's come back to Facebook here. And what am I drinking? What am I drinking, guys, as an IC patient? This is lemonade. I can drink lemonade again. I couldn't drink it for 30 years. Got my muscles fixed. Blood supply was restored. My bladder wall healed. I can drink lemonade now. I drink lemonade every day, and I have been for 2 years. Never flared me. Would have killed me 25 years ago. It did kill me 25 years ago. Shelly said, okay, here, hold on a sec. David says he uses Linzess for constipation. And says the doctor wants you to take magnesium citrate. Miralax, Johanna says, and Senna. Guys, understand that Senna is not something you want to rely on. It is a stimulant, and the problem with stimulant laxatives is that if you use them regularly, your body forgets how to do it on its own, and you can become very dependent on Senna. So try to keep the Senna down. Try not to use stimulants. To have healthy bowel movements, you got to have healthy muscles, and you have to have a good supply of insoluble fiber. A woman needs to have 20 to 25 grams of fiber a day. A man needs to have 25 to 30 grams of fiber per day to have healthy bowel movements, along with drinking enough water. Shelley says, can somebody have multiple phenotypes? Absolutely. So my lead phenotype is pelvic floor dysfunction. My second phenotype is widespread pain. And that is because my original injury was never treated, and it eventually progressed to the point that my central nervous system became injured. So I have very sensitive skin, a wicked sense of smell. All those things are all originating in that original injury, and also some childhood trauma that I went through. Kathy said, unfortunately, the doctor found Hunner's ulcers in mine, but I still feel my pelvic floor is messed up. Well, yeah, that's what I call the chicken versus the egg dilemma, which comes first. For some people, the bladder injury happens first, their bladder screaming in pain, and the muscles get tight to protect you from that pain. That's absolutely possible. That's a chemotherapy patient. That's a UTI patient. But for other patients, it begins with a muscle injury, and then the muscles get progressively tighter and tighter and tighter. The nerves get involved, and then that affects the bladder through a process known as ischemia. Liz had her bladder removed, and her pain's gone. I'm so glad, honey. I'm glad that you're better. What did they find when they looked at your bladder, just out of curiosity, post-op? What'd they find? Judy said, should I be worried about a CAT scan showing the bladder is thick-walled but incompletely distended? I wonder if I should see a urologist, Judy. That means that you've got a fibrotic thickened bladder wall. And the answer is, yeah, you should talk to a urologist about it. Normally that's going to happen after injury or after repeated UTIs. So we want to make sure that you get a proper workup for that so that we can stop that process. Because the bladder is basically a balloon that stretches when your bladder gets full, and then when you empty it, it comes back down. But if you've got a thickened fibrotic bladder wall, so you've got one part that'll stretch and one part that doesn't. So it's now struggling to open. So we want to try to understand the process underlying that fibrosis that's happening. Becky said, I think I have more than one phenotype. Primary is pelvic floor from a broken tailbone, but I definitely also have some diet triggers. Bladder hydrodistension procedures have helped me in the past. Oh, and I had a urodynamics test that proved severe bladder sensitivity to potassium. Okay. So, Becky, the potassium sensitivity test has been thrown out. It was thrown out 10 years ago because it turns out that pretty much any high concentration of potassium is going to irritate pretty much any bladder, even a healthy bladder. So we don't use the potassium sensitivity test anymore. Also, the urodynamics test is not a potassium test. The urodynamics test is all about testing nerve function. So basically what they do is they slowly fill your bladder with fluid, and then they ask you to tell them when you need to pee. So you're laying there, you've got a tube in your bladder, in your urethra, they're filling it up. They're all looking at you going, okay, tell us when you need to pee. That determines what we call your awake bladder capacity, but it's also kind of testing your nerve sensitivity. So, you go for 30 seconds and then you go, okay, I feel it. And they're like, okay, do you need to pee yet? And they're like, no. And then they feel a little bit more and think, okay, I need to pee. And that's an important quantity for them. And then they go, okay, now tell us when you first feel pain. And so you're like, so now you're in a very, very uncomfortable position because your bladder is very full. And they're watching you going, okay, when does it hurt? When does it hurt? Okay, it hurts. You can stop now. And they go, well, let's just push it a little bit. No, you can stop now. And hopefully they listen to you and they will stop and empty your bladder. And that's all about kind of testing the way your nerves are working in your bladder. That's a urodynamics test. Liz says, I definitely have autoimmune markers and my doctor refers me to me as a unicorn. Interesting. Very, very interesting. So I wonder if you were in the kind of lupus Sjogren's group. Anne says, Urabel helps, a flare, but it's so expensive. Yeast was checked. Okay. Linda said, okay, here, hold on. David said, have I heard of Sunobinop? I have, but I don't remember what it is. Hold on, let me look it up. It's an investigational treatment in phase 2 trials. Is that one of the ones? Oh, yeah. Well, we did the clinical trial recruitment for that. Yeah, we did that like 2 years ago, and they just finished the study and published the data this year. Yeah, so that is a new therapy, and I talked with the clinical trial. No, I talked to the research director of the company. He sent me an email maybe 2 months ago or 3 months ago to share the good news that they had good data, good results from that new treatment. And that this fall, they are going to be moving to the next level of study, a phase 3 trial. So when that is out, I will be able to tell you about that, but that is not available yet. Linda said, I think I've finally found some pain relief. First, I started estrogen cream. Also, I was having a nerve issue in my feet, and my doctor did blood work. My B12 was low on the scale. I've been taking B12 for about 6 weeks now. And lo and behold, most of my bladder pain has stopped. I've never gone this long without the pain. I still pee 50 times a day and night, but I don't hurt. Just wanted to share that. Linda, thank you. That's very, very interesting. It is very common for women in their 40s and older to start seeing pretty significant drops in B12 levels. I think they found that for me when I was like 48. 47, 48. I've been on B12 ever since myself. So that's one thing that would help us understand why your nerves might have been a bit more sensitive, but I'm really, really concerned about the fact that you're peeing 50 times a day. That means that something is still going on that is not being addressed well. So concept number one is, do you have estrogen atrophy in your bladder? And is that why you're peeing so frequently? Because you've got your bladder wall can't defend itself now and urine's very irritating? Or is there something else going on that's making you pee so much? You guys, if for any complex patients, you're always welcome to give me a phone call. I am happy to talk to anybody, no charge. You just call our 800 number. I'm always happy to try to help you understand the phenotypes and try to help you understand kind of the treatment priority for each phenotype, and also help you understand this, some of the other products and stuff that are available that would help you. You just have to understand that in our guidelines, especially our 2014 guidelines, we had a 6-step treatment protocol. We want you to start with the easy stuff with the fewest side effects before you go to the harder stuff. And so in the end, every single patient has to start with self-care. You have to learn about IC. You got to fix your diet. If you're a junk food junkie, you got to start drinking water, work on stress, work on anxiety. That's the foundation of it all. Understand, anxiety amplifies bladder pain. Anxiety will have you running to the bathroom more. Nobody's saying that you have mental illness. This is not mental illness at all. This is just what happens to a body that has been injured. It just is what it is. So we all start with self-care, myself included. And believe me, I'm working really hard on self-care right now. And then we phenotype. We need to figure out what your phenotype is, and your treatment is going to be dependent on your phenotype. Paola said, yes, I believe that's what's affected me most. Reading everything online in those support groups and hearing I won't feel better until I found you. Then I deleted every single group on my phone and my healing began. I'm so glad, honey. It breaks my heart that I have to say that, but it's honestly how I believe. I just feel like social media has done a tremendous disservice to the IC patient population and to any patient population, to be quite honest. What astonishes me now is that people are going to TikTok to learn about IC. How the hell is TikTok going to educate you about anything significantly? I had a patient say to me, I will never go to your website. I will never read anything you write. I want videos. And that's why we created, I have a whole free video masterclass. But then she said something else. She said, I don't want a long video. I want a short, funny video. Give me a 3-minute video. Teach me everything in 3 minutes and make it funny. That's a brain that has been trained and damaged by TikTok and short videos. We have to take the time to commit to learn stuff. And that's not going to happen on TikTok to any great degree. Melly Mel said, I had a hysterectomy in 2023, just had an exam, was told that I have a cyst blister, which is common because I had the robotic surgery. He said sometimes that happens. Any suggestions? He said to have surgery on it. Melly, how big is it? I mean, he's right. Listen, if you got it, I had a hysterectomy 8 years ago. We got to figure out what the hell that cyst is. And if it's infection, man, you got to get that out of you. So is surgery in your future? Probably. I mean, how big is it? If it's a little tiny thing, probably not. But if it's like bigger than an almond or a walnut, if it were me, I'd want somebody to look at that and help me understand what that is, because we don't want it to grow over time. So what do they, I mean, you're fresh from your hysterectomy. It takes at least a year to recover from a hysterectomy. That was very, very true for me. So you're at a year and a half maybe right now. But certainly at this point in time, you would probably be having an MRI or a CAT scan to try to understand what that cyst is. And if you've got pain from that cyst, man, this is urgent. They gotta figure that out. I don't want to alarm you. I'm just very, very aggressive now with my medical care. I've always said, I don't like guessing. I want facts. If I'm in pain, I want somebody to look at it and tell me why I'm in pain. Having breast cancer really changed me. And I'm much, much more aggressive about my health now. I mean, it just boggles the mind that you think you're fine and you go have a mammogram and they tell you have cancer. So I have a lot of PTSD over that, to be quite honest. But I certainly would want to know what that is. And if it's, they could have left something in you. That could be a sponge. It could be something infected. I would want to be very assertive with them. They need to figure that out, in my opinion. And anybody who says, that's why an MRI would, I think, probably be reasonable, because that's going to give them the best third-degree look at, three-dimensional look at what that could be. I would really want to know if they left something inside, like a sponge. So I would at least have an MRI or let them do more testing. Do not just walk away. Shelley said, how often should you use a wand? It's not my favorite thing to do, but I feel like I need to embrace it more. Well, if you have severe pelvic floor dysfunction, you may be doing it every day. Every day. And then, you will quickly learn how a healthy muscle feels versus a tight muscle. And as you continue to work on these muscles, they should start responding. And so now I do it maybe once a month. But if I'm in pain, I listen to my body. And if I start having pain and I know what it feels like, it's a tension, pulling, pushing, rectal pain, that's when I do it. I let the symptom drive my decision to do it. Anne says she has lots of vaginal burning. Yeah. Johanna said she's jealous of the lemonade. Oh, girl, I got to tell you, I went shopping yesterday and I went to the bookstore and they had something called a lemon fluff thing. And I don't get drinks or anything like that. I can't, because I can't do coffee and I can't do milkshakes. It's just a long story. I feel quite deprived. And so anyway, this store had this like lemonade with a non-fat milk and ice. And I'm like, okay, yeah, I'll try that. Oh my God. It was so sweet. I drank, like it was like this big. I drank that much and I threw it away. I felt like I was imbibing raw Snickers bars. There was so much sugar in it. Judy says, how can you reach me? Here, let me move the phone number. That's how you can reach me right there. My email address is really easy, icnetwork@mac.com, short for Macintosh computer, no hyphen. Michelle said, I've been online for a while. You're looking lovely and well. Oh, thank you, hun. I will tell you, it's been a rough couple of years. I feel like I've aged 15 years in a year. The breast cancer was horrific. I feel really significant PTSD, to be really honest. I have a lot of pain here in my incisions still now. Apparently, I'm in the top 5% of post-op pain. Thank you very much. But I think most of all, I've been struggling with anxiety and depression to a certain degree. Not severe depression, but I've just been kind of questioning everything. And I've done a lot of therapy, and I did EMDR therapy over the breast cancer diagnosis and my parents dying. But, it's like, it's a new life. It's a new you. And I find myself struggling to make my new life, my post-cancer life. It's very, very hard to explain. But every cancer patient goes through it. So I have a lot of anxiety over doctor's appointments. I have a lot of anxiety over appointments in general. So I'm doing my deep breathing. I'm doing everything I can do it. And it doesn't help that one of my medications is known for causing a little bit more anxiety and depression. So, but I saw something that really helped me. And it said, if you're sad, you're focusing on the past. And if you're anxious, you're focusing on the future. You have to focus instead on the moment. And I find myself going back to the fear of the cancer. And that's really helping me, because now as I'm driving around doing what I'm needing to do, I'm like stopping myself from doing that. And I'm just saying, okay, I'm driving right now. I just took my car in for service. It passed with flying colors. We got a recall fixed. There were no problems. Or yesterday I was driving up to see my sister. It's like, I'm in the car right now. It's a beautiful day. And trying not to get drawn into the sadness of what happened. And it's working, but it's a hard work. It's just really hard work. So thank you. I'm trying. Linda said, my bladder doesn't hold hardly anything, just the amount of a small Stixie cup. It's pretty damaged. Okay. Do we know why it's damaged? And I want to remind everybody here, there will not be a meeting next week because my sister is having her birthday party. Birthdays are very weird when you're older. I'm just telling you right now. I haven't celebrated a birthday in 2 years. Just trauma. Trauma. Anne says, I'm constantly getting checked for UTIs. I had 3 in the last month. They were all negative. Okay, so Anne, they were negative. So you got to let the UTI theory go. And instead, we have to look for other things like the estrogen atrophy. The estrogen atrophy can cause, that would explain all the pain you're having. Melly says you're not sure, but it's painful. Okay, well, Melly, listen, the fact that that cyst is painful means I would be knocking on the door of my doctor or whoever did the surgery and say, you got to fix this. You got to help us understand what this is, and we need some attention here. And so is that going to be a laparotomy? Probably, but it's not as bad as having a hysterectomy. I mean, a laparotomy is pretty much an in and out procedure. But it's never my place to give anybody medical advice. I'm not giving you medical advice. I'm just trying to give you context here. And that is that you have something that is painful post-operatively. A doctor has already linked it to the hysterectomy. So something may have happened during that hysterectomy. Either they introduced an infection or some foreign matter. Let me tell you a true story. I'll tell you, this is so interesting. I was at a local pub that did trivia night, and I sat with a couple of ladies, and we had a great time. And at the end of it, we were all asking what we did, and one of them was a retired doctor. She's an internal medicine doctor. And she's like, what do you do? And I said, I work with interstitial cystitis patients. We had this really interesting discussion. And I was talking about all the unusual cases. And she goes, well, let me tell you what happened to me. And I'm like, okay. She said, right before my retirement in my 50s, I started feeling like I kept having bladder infection. And it was really affecting my ability to work. And so just like you, I went to the doctor, and the doc told them my symptoms, frequency, urgency, pressure, pain. The doctor said it was all in my head. Understand, doctors are quite mean to other doctors. Do not expect a soft landing when you're a doctor going to another doctor for care. And this doctor actually said to her, I think it's all in your head. And she eventually had to go out on leave. Her symptoms were so incredibly persistent and severe. And then she said, one night, as I was sitting on the toilet, I felt this overwhelming urge to push. And so she pushed. And she felt something pop out of her. And she looked in the toilet, and it was a blue suture. It was a little piece of a suture. And she looked at it and she went, well, son of a gun, how'd that get in there? She goes back to the doctor with the suture and said, hey, this came out of my body. Well, it turns out that she had had a tummy tuck a couple of years earlier. And because she worked at a university, they let a young doctor do the surgery. And he used the wrong stitches. The blue sutures are not dissolvable sutures. Those are the sutures that you use on the skin that you cut and pull out. Her belly on the inside was filled with dozens of blue sutures that were now moving throughout her entire abdomen, causing damage. So they had to open her up and try to find all these blue sutures. And once they did, her urinary symptoms disappeared. So, and this can also happen after vaginal mesh surgery. If you've ever had a prolapse and they repair it with mesh, sometimes the mesh moves and sometimes it travels through the bladder wall. So the point that I'm trying to make here, Melly, is that things happen during surgery. And I would not want you to wait another year. I would say, guys, I need you to look and tell us what this is. That would be the way I would approach it. But then I'm very aggressive now. you know. Diane says, can we take B12? Yes, of course you can. You say the B vitamins could cause bladder wall flares. Only B6. All the other B vitamins are fine. B12 is absolutely fine. And B6 doesn't bother everybody. It only bothers some people. Kathy said, where can you buy a wand? You can buy one from the IC Network. We've got several in our shop. This one, we don't sell this one anymore. The company that made this was bought by Desert Harvest Aloe. So you can buy this last wand from Desert Harvest. And this is my favorite wand. I mean, this is my demo, but I have one in my bedroom that I use. The reason why I like the last Pyrex wands, they're really, really easy to clean. They're really smooth and easy to use. And the shape is important. This is a great shape for a wand. It just helps you reach farther. Melly says, you're right, because it can cause an infection if it ruptures. Absolutely, girl. The last thing we need is for you to get have a systemic infection. Man, I would just like being knocking on their door tomorrow morning. Or if the doctor that you saw already suggested surgery, well, then schedule that surgery quickly. That's the way I would do it. I'm not saying you need to do it, but if it is infection, we want to nip that sucker in the bud. I guess what's motivating me to say that is that I had breast cancer. And if I had waited 6 months and not had that surgery quickly, I would be in a much more difficult situation. I was very, very lucky that we found it early. And even though I had a lot of it, it was contained in one small area and it didn't hit my lymph nodes, which is why I still have hair and didn't have to go through chemo. But that's one of the challenges that I have is my brain. There's a part of me that goes, wow, if you had waited even a month, even 3 months, even 6 months, you know, I shudder to think of what my life would be today if I had waited and that cancer had spread. It's like living with a sword over your head, you know? And I'm cured. They say that I am cured. I am 97% cured. The the surgeon oncologist said, because I had both breasts removed, and believe me, they didn't just remove, man, I am hollowed out on my cancer side. There is a big indentation there. They took everything, even the fascia over my ribs is gone. And she said, in somebody who's had that surgery, I personally have never seen it come back. But what the research shows is that it can come back in 3% of patients. It's crazy. And I get the other thing that just infuriates me is, you know, until you have cancer, you don't understand how many people have cancer. It's endemic now. There's just so many people struggling with cancer. I'm shocked. And I asked my oncologist, why me? And her answer was, well, it's not genetic for you. It's environmental exposure combined with periods of intense stress. The other thing I didn't know is that sugar feeds cancer. And I was eating a lot of sugar. I try not to eat sugar. I very, very little sugar now. Kathleen said, regarding the urodynamics test I had done in 2019, my bladder was filled with 500, 600 ml. I still did not have the urge to urinate. The PA, physician assistant, questioned voiding disorder or pelvic floor dysfunction. I self-cath 3 times a day to empty residual. Wait a second. Your estrogen dependent. Wait. Estrogen dependent neurogenic bladder. Had this for 7 years. Seeing a new urologist tomorrow, not an IC specialist. None available around here. Last 3 UTIs were almost white, cloudy, lots of blood, leukocytes, almost foamy urine. So, have you been diagnosed with neurogenic bladder? That's number 1. Number 2, do you even feel an urge to urinate, or is that missing? Because if you don't even feel when you need to pee and your bladder is filling up with hundreds of cc's of urine, then that would help us understand why you've had some really bad UTIs, because you're just not draining, you're not emptying. So that's not IC, honey. IC doesn't cause that. That's the fact that you're self-cathing 3 times a day to empty your bladder. I'm glad, and when you go to see the urologist tomorrow, don't bring up IC to start with. You just need to say, listen, I have to catheterize 3 times a day to empty my bladder, and I don't understand why. I've had, is this a voiding disorder? Is this, which it doesn't sound like, is it neurogenic bladder? Yeah, it kind of sounds like neurogenic bladder if you don't even feel the sensation to pee. But I would also wonder if we're dealing with any nerve damage up like by L4, L5. You go and be aggressive. I want to be able to urinate on my own. Can you help me understand why I can't? Sue said, I had almost 2 years out with my hysterectomy and could hardly sit. Found later I had a torn hip, which can happen during surgery because they don't always support you properly. Doctor did not acknowledge it, even though Dr. Peters knew right away when I went to see him. Yeah, Sue, you bring up a great point. Surgical injuries happen, and probably once a month I work with a surgical injury patient, somebody who had some sort of procedure that created an injury that has led to their issues. Shelley said, thanks for your answer. I greatly appreciate your Sunday Live. You are welcome. One of the reasons I think I feel really good right now is because I went to the gym this morning. If I don't go to the gym every day, I find myself getting sad and depressed. It's very important for me to move my body and to go work out and to just produce some endorphins. Yeah, Sue, I understand. Linda said, it's all scar tissue, they said. Why? I was assuming it was from the cauterization I had from the lesions. It could be. Anytime you have cauterization, it's going to leave scar tissue, but sometimes scar tissues can happen, from repeated infections too. Melly said, oh my God, yeah, about the blue stitches. Is that wild? Diane said, I go this Wednesday for my second treatment of steroid shots into the bladder. I'm anxious about it because when I had it in March, I felt dizzy, anxious, and unbalanced for 10 days afterwards. Thought it was the anesthesia, but now I think it was the steroid shots. Can you have systemic side effects from steroid shots to the bladder? Well, listen, anything can happen. And the challenge with getting shots in your bladder is, have they accidentally hit a blood vessel and injected the medication into a blood vessel? That would then spread it throughout your body. I think you need to tell your doctor what happened. And let's see if your doctor has had any other patients experience what you went through. Anesthesia, I can remember when I had my first laparotomy for my IC, I had problems for probably 3 to 4 weeks afterwards. I would have kind of waves of dizziness. That was the days before propofol. Propofol now is a fantastic anesthetic, quick acting anesthetic to knock you out and wake you right up, where before 30 years ago, they did other things. And what's hard about that is I was actually co-chairing a nonprofit conference a week later, and I remember speaking to hundreds of people dizzy, and that did not go well. I was not in my best shape after that. So talk to your doctor about it and let them know, and see if they've ever had any other patients report this. And when you check in for your outpatient procedure, talk to the anesthetist about it. I mean, normally when you have outpatient procedure and you check into the hospital, the anesthesiologist comes out and talks to you. So make sure you talk to them and say, listen, the last time we had this done, I was dizzy for days afterwards. And I did not feel normal at all. And I don't know why. That could have been from the medication they used, or maybe that was from the anesthetic. Have you ever seen that before? And more importantly, can we maybe mix it up and maybe do something that isn't as strong? You know, what I said to mine is, I just want to be able to pee quickly. Because when I had my first laparotomy in 93, I couldn't pee for about 12 hours and they sent me home, which you're not supposed to do. And I remember being in a tremendous amount of pain until finally my bladder woke up and I could pee. And so when I had a DNC before my hysterectomy, I said to the anesthesiologist, I explained what happened the first time. And I said, listen, all I want to do is be able to pee. That's all. If you can give me an anesthetic that doesn't put my bladder to sleep so that 15 minutes after I wake up, or if I'm in the recovery room, I can go empty my bladder, we're good. He goes, yeah, I can do that. We use propofol. And I'm like, when? When? And it was perfect. I literally could pee 15 minutes later. And then when they decided that we had to do the hysterectomy, and I went in for that, I said the same thing to him. I said, I just want to pee afterwards. You know, I don't want you to send me home not emptying my bladder. And he's like, well, yeah, but you're having hysterectomy. We got to be a little bit more aggressive. And I went, yeah, but I need you to be, I don't want you to be that aggressive. Please help me urinate afterwards. And it was fine. Even after my hysterectomy, I was able to pee within 15 minutes. So life, right? Melly says, I get it. My gut is telling me not to wait. So you made it easier for me to make this decision. Glad you're okay. Bless you. Very traumatic. Melly, would you do me a favor and let me know? I would really love to hear when, what's going on. I'd love for you to keep in touch with me and pop me an email or give me a phone call, especially after you have it removed, because it's very important that we gather these reports so that we can share them with others. Because if this was a surgical mistake, and listen, if they left something in there, then you need to be compensated big time. Yeah. So if it's a simple post-op infection, that's nobody's fault. That's a risk of surgery. They need to learn from it, adapt, and make sure that they're following all of their proper bacterial controls, which they would normally do anyway. But infections happen. I mean, I had a post-op infection in my right incision after my surgery. That wasn't anybody's fault. It just happens. But if they left something in there, that's a whole nother story. I hope they didn't. Kathy said, so glad you found it as early as you did. Yeah, totally. And I owe that to Patty, who's one of my members, who had called me in late May to tell me she'd just been diagnosed with breast cancer and wanted to know how to get through chemo. And as we were talking, I went, oh man, I need to schedule my mammogram, because I was going to put it off 6 months. And I'm listening to her story going, oh, I need to go do that. And so while I was talking to her, I logged into Kaiser and I scheduled it. And that's when they found it. And so she knows that she saved my life, in my opinion. So she can call me anytime she wants, 24 hours a day. I've already told her, I am in your debt forever because you helped me find my cancer. And so she calls regularly. And I'm so appreciative. I'm happy to talk to her anytime. Kathleen said, I feel the urge to urinate. I void, then cath to get the rest of the urine out. I suspect nerve damage. How much are you cathing out, hun? Like, how much are you getting every time you cath? So that's very interesting. Thank you, Cher. Cher says, just sending love to you and all you do. Thank you, honey. Really appreciate it. Denise said, that's horrible. Yeah. Life is difficult right now for lots of people, for lots of different reasons. Francis said, my pelvic physical therapist is recommending the pelvic wand after months of going and wondering if anyone here has gotten the vibrating one from Intimate Rose. Honey, we have it in the IC Network shop. You can buy it from us. And yes, definitely. You know, one of the barriers here is that as soon as people mention wand and vibration, they think sex toy. It's not a sex toy at all. That when you give some gentle vibrations to that tissue, it can be quite helpful. And so the vibrating wands are fantastic. The hardest part of having a wand is just learning how to use it. That's all. I mean, there's just a learning curve. And, you know, the first couple of times, I mean, realize I read everything. So I consider myself very informed. And yet, so I had my wand. I didn't know what the hell I was doing. I just stuck it in there, just like, okay, what do I do next? And you know, the light bulb wasn't turning on for me at all. I had no clue how to use that wand. And then, so I call the physical therapist back or text her, and I'm like, okay, I'm so confused. What am I supposed to do with the wand? And she said, you move it in a J shape, like a capital J. So, right? Little curve up. And I'm like, okay. So then next time I tried it, I tried to do the J shape. Nope. Right over my head. Made no sense to me. No sense to me at all. I'm like, where's the J? I mean, I'm Jill. I understand what a J is. So I just like, where is it? And it wasn't until I read, where is it? It wasn't until I read this book, Breaking Through Chronic Pelvic Pain by Jerome Weiss, that has very detailed drawings of the pelvis, that the light bulb turned on. Okay, so I'm going to teach you the J shape. So, okay. So we're looking at the pelvic cavity again. And you can see the tailbone right here, right? So the tailbone is the foundational structural center of the pelvic floor. So you've got muscles that attach to the tailbone that go to the left, and muscles that attach to the tailbone that go to the right. That is your J shape. Little curve and up. Little curve and up. So if we're doing it from the back, little curve and up. That's the J shape. It's like, oh, and I guess honestly, I just really didn't understand that all these muscles attached to the tailbone. Like I just didn't, I mean, I knew they were down there. I just really didn't understand the structural role that the tailbone plays, that it's the center and you've got muscles on this side and muscles on this side that mirror each other. And then, you know, when you start using the wand and you start learning what healthy muscle feels like as compared to tight muscle, I mean, that's the most powerful moment, is that, like, if you put that wand in and it hurts, there's a problem. It shouldn't hurt. And so again, when I'm using it, I'm gently inserting it into my vagina and I'm just looking for tender spots. And generally for me, my tender spots are low. They're not up by my tailbone anymore. I mean, we've done a really good job. I've done, not we, I've done a really good job with this. Most of my tension is right down here and right in this area. And that I think is just because I sit for long periods of time working, you know. I mean, we're just dealing with kind of wear and tear, and we're dealing with how we feel today is a direct reflection of what our body has gone through in the previous 24 hours, you know. And if you sat for 10 hours, odds are your pelvic floor is not going to be very happy with you. I now, when I work, I have one very, very clear rule, is if I'm on the phone with anybody, I am not sitting here. I am up and walking around. And I just know at the age of 65, I cannot sit for long periods of time anymore. Back when I started the ICN, I could sit here for 10, 12 hours writing. I mean, that's how it was built. I could read and I could write for hours. I can't do that now. I cannot sit for long periods of time. And sometimes when I get up, I'm really tender and sore, especially on my left side, SI joint. Francis said, same for me, low. Judy said, how far do I go in with a wand? Well, it's not like it's you can't go far, honey. Your pelvis is a small area. So the other thing too to understand is that normally it doesn't hurt. It's only going to hurt if you've got trigger points or tight muscles. So I'm not afraid. It's so fascinating. I can remember with one of the physical therapists that I was working with, she was over here and she was actually touching the bone with her finger. And she's like, yeah, that's your hip bone. That's this. And it didn't hurt at all. And I was just stunned. So I would say that I could easily go, a finger length, like 3 inches. But it's really rare that I find pain there. Usually I'm focused right down here. So it's only an inch and a half in. And there's a really important rule here is, so sometimes if you have a trigger point, which means that you have a muscle knot, so normally, like if you had a muscle knot in your back, you would have somebody push on it and rub on it because that breaks the muscle knot up. So if you have a muscle knot in your pelvic floor, you do the same thing. You gently push on it, massage it, and try to break it up. If you ever push on something and you get sharp nerve pain, you stop immediately because you are pushing on a nerve. And I have this one spot on my right side that's kind of low. And if I push hard there, I get a zinging pain up my left side. So you got to really listen to your body. Hurting, if anything is hurt, if you're manipulating it and you're triggering a lot of pain, your odds are you're being way too aggressive. and you got to back off and have the physical therapist show you what to do. As soon as I feel nerve pain, I'm out of there. No, 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 no. I am not interested in hurting a nerve. Diane said, I found it more helpful with relaxing my pelvic floor. Yeah, sure. I mean, there are deep breathing, belly breathing, certain stretches and exercises. That's always part of it. I think one challenge that we all have right now is the world is just very stressed right now. And like pretty much everybody that I'm working with, from peers and professionals to patients, the anxiety level's off the charts right now. And we have a lot of people now, a lot of my clients now who are very, very worried about not getting food. Our low income disabled patients who get SNAP, they're terrified. And I have a family member who works for the FAA, hasn't been paid in 6 weeks. I mean, this is affecting a lot of people now, and there's a lot of fear. So I think that, as I've said, and getting off of the internet, not watching the news, and every single day doing something that will bring you joy and comfort. Like, we just want to go back to life before social media and the internet. Like what did we do 20 years ago? Well, you know what? We went out and walked. We talked to our neighbors. We talked on the phone with friends. We went out for lunch. We went to the movies. And we weren't all glued to a phone that is deliberately making us upset every day to make money, because that's how they make money, is by keeping us upset. And so the algorithm is specifically designed to make you stressed out. And I'm like sick of it. I'm the effing sick of it. So like I'm doing stuff. I'm trying to go back to the good old days on my daily routine. I paint a lot after work. I had a night I watched I Love Lucy I watched like 3 episodes of I Love Lucy. I watch a lot of K-pop. I like K-pop. I watch Korean dramas on Netflix, but I am not doing politics. I'm not watching the news. I am just like, it's not healthy. And Kathy said, yeah, social media is so bad for your sanity. I mean, and for those of us who have already gone through a very, very difficult time, and I lost my parents, I had 2 emergency surgeries, and I had cancer. And a year ago, even though you can watch my meetings, I look fine. Honey, I was on my knees crying every damn night. Exhausted, angry, frustrated, scared. And so to be that vulnerable and then be drawn into a social media world that is designed to keep you upset was so not healthy for me. I truly feel now that social media is poison. I think it's poisoning us. And so, like 30 years ago, the web was great for sharing information. It was wonderful. I mean, like I have a business on the web. I have the IC network. I'm grateful for that. But that's not social media. Social media is a very different beast. And social media's entire purpose is to make money for companies. And the way they do that is by keeping you engaged. And the way they keep you engaged is by making you upset. And now we've got lots and lots of people who they're just lying about everything. It doesn't matter the topic. They're just trying to make a buck. They're trying to get you to watch their video. They're trying to get you to watch their short. They're trying to manipulate you by keying in on your emotions. And I'm done. I don't read social media anymore, other than occasionally a little bit of Twitter, because there's just a couple of people I follow, mostly farmers. I don't come onto Facebook and spend time reading messages. If I am happy to talk to anybody about IC, call me, email me. But I refuse to give a social media billionaire another moment of my time, of my free time. Rebecca said, I started a statin for cholesterol. Now my bladder's been worse for the past few days. Yeah, that's actually common. Statin medications can certainly be a bit more challenging medications. So I would like to do a small study on finding the best high blood pressure medication and statin medications for patients who are having bladder reactions to it. I don't know if this is short-term or long-term. I just don't have any data on that at all. I think that you could reach out to your doctor. You know what? What's the name of the med, hun? Let's look it up. Let's see if that medication is known for causing bladder pain or bladder symptoms. If it is, you can go back to your doctor and say, hey, I think we need to try a different one because this is killing my bladder. So what's the name of the med, hun? Francis said, my first therapist was the same way. I gave up and left for a whole year and only back because the pain went back. This new girl is phenomenal. Night and day difference. She's doing dry needling, stretching, foam rolling, and now a pelvic wand. I guess not every therapist is the same. It's all, Francis, it's all about their training. We have to go to a pelvic floor certified physical therapist. And the best place to find those is at a website called pelvicrehab.com. That's short for rehabilitation. So pelvicrehab.com. That's the best online database to find physical therapists who have been trained. So clearly the second one was trained. The first one wasn't. Understand that when somebody goes to physical therapy school, pretty much the only pelvic physical therapy they're taught is for incontinence. So if you go to a physical therapist who says, hey, you need to do Kegels, and you're going for pelvic pain, they're not trained. Because Kegels are used to strengthen weak muscles. The problem with us is we have muscles that are too tight. And the last thing we should do is tighten muscles that are already too tight. And our national guidelines are very, very clear that we do not do Kegels with tight muscles. Our goal is to relax and release. So if you have a PT who's telling you to do Kegels with a pelvic pain diagnosis, you got to ask a lot of questions because that means that they're not trained properly. Okay, so Rebecca's taking Prevestatin. So let's look this up. So I'm going to do, here, hold on a sec, just to show you. Okay, I'm going to show you my desktop. All right, so whoops, hold on a sec. So this is the YouTube stream right over here. So let's drop this one down, and that's an OBS thing. So let's open up a browser here, and we're going to go to, okay, here, hold on. Did I cut and paste that already? All right, where did that go? Hold on. I got to find it again. Okay, Prevestatin. So let me copy that. Now, for you guys on YouTube, I can't show you my screen, so I just have to describe it. All right. So let's go for prevestatin side effects. Let's just see what they are. Now, you know, AI, obviously on Google, AI is like the first thing that you see, but it's not necessarily reliable. So let's go to Mayo Clinic instead. So prevestatin is used with a proper diet to lower cholesterol and triglycerides in the blood. Okay, so let's scroll down to side effects. Here we go. Most common, difficulty with moving, muscle or bone pain, muscle stiffness, pain in the joints, localized pain. Less common, arm, back, and jaw pain, chest pain, chills, cough, dark colored urine. So that's interesting. Diarrhea, difficult labored breathing, ear congestion, fast heartbeat. That sucks. Fever, feeling ill, headache, loss of appetite. Okay. Is there anything else? Okay. Let's see. Here you go. Difficult or painful urination. So your experience is legit. And here, hold on. I'm going to go back to my face here. Your experience is legit, hun. So you need to call and tell them that you are having an adverse event. Oh, did you guys not see that? Did the screen not share? No, the screen definitely shared. So I think it's perfectly okay to call the doctor and just say, hey, you know what? I'm having difficult urination, painful urination, well-known side effect of prevestatin. What else you got? This might not be the medication for me. Francis said, anybody have an issue with the colonoscopy prep? I'm terrified it will send me into a flare. My doctor is bugging me about it. Actually, Francis, hold on a sec. Because believe it or not, this is a very common, such a common question that if we go to the IC network, whoops, that's Canva. Hold on. All right. So we're looking at the IC network website. Let's just put in here colonoscopy. Whoops, hold on. Please sign up for our newsletter. It's free. So we're going to put in here colonoscopy preps. There you go. Colonoscopy tips. IC flares rarely happen. It's a reality we all eventually face, the dreaded colonoscopy. This vital test is recommended after the age of 50 and can help detect cancers in the GI tract. Despite its potential life-saving effect, many patients go out of their way to avoid the test for a variety of reasons. For some, it's just embarrassment of having somebody look up there, but for the IC patient, often the fear of triggering a flare. We've received dozens of calls from patients who were worried that it could trigger more bladder pain. The good news is that very few patients have reported bladder irritation after colonoscopies, but you should do some planning in advance to make it easy. Anyway, I'll let you read this article, you know, how is it done, choosing the test date. You can tell the doctor about your acid sensitivity. I personally did the Miralax protocol. So I used Miralax and Gatorade. Very, very easy on my bladder when I had it done. Some of the bigger other preps, like Go Lightly, have more citric acid in it. They have the potential of potentially being a little bit more irritating. But remember, you can also use some pre-leaf to reduce the acid of the prep. And believe me, when you're doing the prep, you're not going to be thinking about your bladder at all. You're just going to be sitting on the toilet, just waiting for things to clean out. One of the things that I will say, a couple of things I will say about the Miralax prep. My doctor said, reduce your roughage like 4 or 5 days before. Just start eating much lighter meals. That way, less icky stuff is going to come out. So not the time to have a steak. It is the time to have chicken noodle soup. With the Miralax prep, I would get 2 different flavors of Gatorade. If you don't want to do Gatorade, you can just do water, or you can do a little bit of water and juice. That would be fine. Also understand, too, that after it's done, you're still going to stay close to a bathroom for a day or two because you're still pretty slimy in there and things are still going to come through when you start eating again. Really, really important when you're doing your prep that, man, this is your bathroom. Nobody else needs to use it. Nobody else gets to use it. That is your bathroom because you will be running to that bathroom for that 5 or 6 hour period. And I hope it goes well. I wouldn't worry about it at all, hun. I wouldn't worry about it at all. There you go. All right, hold on a sec. I gotta. Crystal said, how do you sign up for the newsletter? Crystal, just go on over to the IC Network website, icnetwork.org. You'll get a pop-up window and you just put your email address in there, or you can go to the newsletters area and there's a link that you can use to sign up for the newsletter. I only send out, basically one a month, one every 2 months. And by the way, I gotta say, listen, I have a real thick skin because I've been doing this for a long time. And I had somebody get very mad at me with my last newsletter. They said it wasn't scientific enough. And my answer back was, well, some are scientific and some aren't. It depends upon the topic. And then I had somebody else email me and say, that was one of your best newsletters yet. So I had one person who was furious at me with me and one person who was like, rock on, Jill, you're doing a great job. Cher says, tiny news for awareness. Yes, keep going. Do what you are able in your personal life and leaving treasured imprints on other hearts. The number 2 greatest gift God gave us is each other. Cher, beautifully said. Totally agree. I mean, don't you just sometimes I find myself feeling a little lost, because this isn't the life that I thought I was going to have. And it's very easy to get lost in things that didn't happen. And regrets. I don't have, my regrets are in what I see in pelvic pain stop me from being able to do for decades. And now I can do those things, but now I'm old, damn it. I'm older. Diane said, sorry, Jill, I missed when you responded to my question about steroid shots to the bladder, possibly causing systemic side effects. I was sending my granddaughters home with their mom. I think you just need to tell your doctor about what happened. You have to understand anytime they inject anything into your bladder wall, there's a chance that they accidentally inject it into a blood vessel. And that might be why you had more, a greater reaction to it. Maybe it accidentally got into a blood vessel. You got to tell your doctor what happened and tell the anesthesiologist when you go back. Remember, when you check in and they're prepping you to go have your hydrodistension, if you're having an outpatient procedure, that anesthesiologist is going to come out and talk to you. You talk to them and say, okay, this is what happened the last time. I was kind of dizzy for 10 days, and I don't know why. I don't know if it was a steroid, or I don't know if it was the anesthesia. And so I would like you to think about that. And is there something we can do or something we can change to make sure that that doesn't happen again? And again, propofol has become kind of the anesthesia of choice. Propofol is the anesthetic that killed Michael Jackson because he was untended and using a lot of it. But as an anesthetic for an outpatient procedure, it's gold because it knocks you out quickly, but they can wake you up really quickly. You know, when it's done right, it's a wonderful anesthetic. So I've had it now 3 times, and I wouldn't hesitate to have it again. I love the fact that I could urinate afterwards. Francis said, I'm so scared. I know screening is important, but talk about stress. I do some other IC people didn't tolerate the drinking solution well, but I'm glad it didn't bother you. Remember pre-leave. Okay, Francis, I'm going to tell you my true colonoscopy story, okay? It's actually quite funny. So back when I had IBS in my 20s, I had my primary care doctor at the time decided that he wanted to look up my rectum. And I was not prepared for that. And I was completely awake and I was screaming bloody murder. And I kicked him. He wouldn't stop. I was like 23, 24, and he was forcing something up my rectum. And literally, I kicked him in the face. It was a reflex. It wasn't on purpose. I was just in so much pain. I was flailing. And I'm like, you know, screaming, stop, stop. And he wouldn't stop. And I kicked him in the face. Well, anyway, fast forward 40 years or 35 years or whatever, I get to have my first colonoscopy at the age of 50. And of course, like you, I'm just like, oh, it's not going to be fun. And you know, the colonoscopy prep, if you want to talk about it, I've got a really good system for the colonoscopy prep. That's hard. The hardest part of it is just the damn prep. That's all. So anyway, we do the prep. I am cleaned out as you can be cleaned out. I get driven over, and as soon as you get to the center, you know, you immediately get a bed, and they immediately give you an IV, and which immediately chills you out, right? So, yeah, I mean, you are well treated, warm blankets, we're good. So then my time came, and they wheeled me into the prep room. And so I'm laying there, and the nurse is there, and it's kind of a bigger room, but the nurse is there. And I said to her, okay, a win for me is if I remember nothing. I don't want to remember anything. And she kind of stopped and looked at me and said, well, I can't promise that. And I said, well, you don't understand. The last time somebody tried to look up my rectum, I kicked the doctor in the face. Not lying, it happened. And she was like, huh? Well, the doctor was over in the corner behind a portable wall, and his head popped up immediately. Like I see him, he's like, what? And he comes walking over to the bed really quickly. And he's looking down at him. He goes, are you serious? And I went, oh, hell yeah, I'm serious. I am totally serious. I kicked him in the face accidentally. It was not on purpose. I was flailing. I said, it is in your best interest to make sure that I am knocked out. And he looked at me, and then he looked at the nurse and nodded, and the nurse looked at him and nodded. Nothing. I remember nothing. They knocked me out good, and that was just great. And honestly, I mean, the vast majority of people, the vast majority of people have absolutely no memory. My best friend had one done earlier this year, and she said she was kind of talking to them, and I'm like, yeah, I don't want that. And I asked her if it hurt, and she said no. So, I just want to be, I want to be asleep. There is, by the way, um, uh, oh, come on. What's the name of it? Rhett and Link. They have Rhett and Link. They have the video show, Mythical Morning, Good Mythical Morning. So they have one of the biggest shows on YouTube, and they're really, really funny. And they do every day they have a different episode where they do lots and lots of different things. So anyway, you want to watch one of the funniest things in the world. They got colonoscopies together and they got vasectomies together. Good Mythical Morning on YouTube. So watch it. I mean, there is funniness going on too. So I wouldn't be afraid of having a colonoscopy at all. It's good to have it done. Just get it over with. Man, you can handle the prep. And the odds are everything's going to be absolutely fine. But just do it. So you don't agonize over it anymore. Don't let anxiety stop you. Linda said, I take a statin and have for 25 years. I looked mine up. Wow, I copied and pasted. Rosuvastatin can be associated with bladder issues such as increased urination, difficult urination, blood and protein in the urine. Wow, and it says an increased risk of interstitial cystitis. Girl, Linda, holy crap. This is not my area of expertise at all, obviously. I do bladder stuff, and I take a very light blood pressure medication because my blood pressure is up a little bit. And yet, I think that this is kind of testimony to absolutely how horrific our diet has been over time. With so much sugar and so much fat and so much saturated fat and all that sort of thing. And so I guess the question that I would have is once I've made these changes and I'm not eating cholesterol anymore, do I still have to take the same amount of medication or can we reduce it? Do I even need it? I don't know. I have no expertise in this area at all, but holy hell, if it actually says is associated with an increased risk of interstitial cystitis, I have never seen that anywhere and I've looked up a lot of drugs. Let me go to Mayo Clinic. Hold on a sec. Rosuvastatin. I can remember that when they tried to put my dad on statins, he felt absolutely terrible and he just walked away from it and he lived to 100 and a half. So hold on, let's see. difficult burning or painful urination, fast, irregular pounding or racing heartbeat, dark urine, bloody urine. Holy shoot. Muscle tenderness, wasting, or weakness. Upper right abdominal or stomach pain. What else do we have here? I think it's time to have a discussion with your doctor and just say, hey, listen, do I still need to take this? And, I think sometimes we get kind of, and I mean, it's kind of like when I work with an IC patient who, let's say, is taking Elmeron, and they say, with Elmeron, I can drink coffee and soda. And I'm like, yeah, but with Elmeron, you might go blind. And they're like, yeah, but I can drink coffee and soda. And it's like, yeah, but you might go blind. And so I guess the point that I'm trying to make here is that sometimes people use the medication as an excuse to continue doing something that might not be as healthy for them in the long run. So I would think that if you're on a pristine diet, I mean, is there blood testing they can do to see what they can check your cholesterol levels to see where you are. But I think it's perfectly reasonable to say, hey, man, I started this med 25 years ago. I started developing bladder symptoms after I started taking it. I didn't realize this medication was associated with this. And I want to know, do I still need it? And is there anything I can do with my own life and with my own diet that will reduce my risk of this? Listen, I just had a 42-year-old family member have a widowmaker heart attack. Yeah, 100% blockage in one artery in his early 40s. So medication is important. I certainly understand that. But if you've been on it for 25 years, and I would want to know, are you healthier now? I mean, I don't know the answer to that question, but I think you have the right to ask a few more questions. Rebecca, thank you for the 310 stars. Melly says, well, appreciate you. Thank you for educating us. Got to run? You're welcome, honey. Thank you, Francis. John, my friend John. I wish family and friends understood how debilitating chronic pelvic pain can be. Yeah, we're just in this world, and it's very isolating, and it kind of fills our consciousness with our struggles, and because we don't have the balance of having other people in our lives, and we don't have the balance of potentially seeing that maybe it's not quite as bad as we feel, or at least have another source of joy and a source of laughter. The isolation and the loneliness is very, very difficult. And we've talked about this before, and I feel you 100%. And I'm still struggling too, because I live alone. And, it's not what we envisioned for our lives. On the other hand, we're here, we're alive and kicking. And I just firmly believe that God has a role for all of us. Diane said, I was able to get the colonoscopy prep without any flavors to citric acid and just mixed it with water and had no problems. But then I think I would have if I'd had the prep with citric acid flavors. I asked my pharmacist for unflavored prep. Perfect. Rebecca said that's the first statin they started you on. I mean, yeah, but 25 years ago, that's what they did. But a lot has changed since then. Now we're really prioritizing a lot more kind of diet modification and all that sort of good stuff. Catherine said, I had heard that statins can give a healthy person IC, so I'm sure it wasn't good for somebody with IC already. I agree. Catherine said, now I'm wondering if red yeast rice could also cause a problem. I don't know. Linda said, yes, my cardiologist has me on this. I took me off of atorvastatin about a year ago and put me on this. And Linda said, I have high cholesterol, even with a proper diet and lifestyle. I had a heart attack at the age of 43 and bypass surgery. Okay, well then clearly this medication is very, very important for you. Linda, do you have an idea why you had that heart attack at such a young age? Like, we've been having a lot of discussions in my family because, like, my sister and my brother and I all have now a fairly significant history of stomach bowel issues, gallbladder issues, liver issues, and I had my gallbladder removed a year and a half ago. I had no idea I had gallbladder issues at all. It turned out it was totally blocked. I mean, 100% blocked. Nothing was flowing. The surgeon was like, oh my God, you have the biggest stones I've ever seen. Do you want to see them? And they literally admitted me, and I had emergency surgery to get rid of this horrifically damaged gallbladder. So I blame my Norwegian ancestry because I grew up with butter and cheese and fondue and Swedish pancakes. And that is what we ate my entire life. And even as my parents were old, their favorite meal was fondue. And I made it almost every week, and I ate it too. Massive amounts of saturated fat. And my mother had her gallbladder removed like 25 years ago, and she had to cut back for like 5 years, and then she could do it again. I diet now. I mean, like, my diet is about as clean as you can get now. No sugar, no salt, meat and veg, with, a quarter of the plate is a protein, a quarter of a plate is a veg, a quarter of a plate might be a fruit or a carb. And, and then the carb is in the Rex. And then it's good oils. I only cook with olive oil. I haven't eaten butter in a year and a half. I made gluten-free a muffin before I did this meeting. I put olive oil on it. I'm so used to that now. And I'm now down to, the last time we checked, I think it was 138 pounds. I'm 5'9", and my weight in college was 133. I started at 155 a year ago. So I'm really happy to lose. So Linda said, maybe because I smoked for 20 years. I had quit at the age of 34, but doctors said it was a contributing factor. Yeah, my mom was a smoker too. Your left coronary artery with 90% blocks. You coded on the treadmill. Honey, during your stress test at the hospital. Holy moly. Wow. Well, very, very clearly, statins have kept you alive. This is important. So I guess the question would be, are there any new statins that they've developed that have a lower side effect profile? Worth asking. And I'm so glad that they saved your life. But, as you know, going through a heart problem like that, I mean, here you just like been scared like you've never been scared before, and then they do whatever they do, and they give you a prescription, and they get rid of it. And they send you home like he was home. They put a stent in. Here he has 100% blockage. He has a heart attack. 2 hours later, they put a stent in, and an hour after that, they sent him home. And it's like, what? Because there's an emotional impact and trauma to this too that needs to be addressed. The stress is real and haunting. Diane said, I wasn't able to tolerate statins because I had so much muscle pain. I take fish oil supplements daily and it brought it down by 30 points. I don't have other factors for heart disease. So the doctor said I don't have to take a statin. She did a calculation that showed that my chance of heart problems was under 2%, I think. So no more than typical 60-year-old. I have a heart screening every few years, and it showed a calcium score of 0, so no plaque in my artery. Excellent. Wow, yeah. Yeah, you might as well, Linda. You might as well. You know, I mean, I don't want patients to be patient. I mean, the problem with a patient is that you're waiting for the doctor to tell you things. But the thing is, the doctors are so busy that, you know, man, you're lucky to get 5 minutes of FaceTime with them. And so what I want you to be instead is, we call it a respond, a responsible participant in your medical care. That means instead of being patient, you're firm. Instead of waiting for them, you ask questions, you direct your care. Because in the end, you pay them, they don't pay you. You're the boss. They're not the boss. Now, we have to be willing to do the work. We've got to be willing to do the reading so that we can walk in there and talk really firmly and aggressively about what we want with our medical care. It's really quite vital now, because our healthcare system has changed in the last 10 years. And, you know, I long for the days when we had a primary care provider that we had a personal relationship with who cared for us. I mean, I'm part of Kaiser now, and I feel like I'm just a cog in an industrial wheel, and there's nothing proactive about it at all. Like, the only way I get a response is if I ask a question. And so, you know, my blood pressure has been like 133, 135 over 85, which is perfectly fine. But, you know, people say you need to be 120 over 80. So I was like, well, there's room for improvement. You know, I'd be willing to try a little bit more blood pressure med. Didn't work for me. I tried it last week and I got very, very dry eyes. And by Friday, I could barely work at the computer. And I emailed my doc and I said, yeah, I'm not going to do that. I'm going to stay with my low dose, and I'm just going to work really hard. I'm going to look for some other self-care things that I can do. I have a very hard time relaxing. Like, I don't want to, if somebody says just meditate, I have so much post-op pain in my chest that that's all that consumes me. You know, it's just, I'm just feeling these incisions. And so the way I relax is I paint. I just sit at my kitchen table and I paint. And that's my meditation. And the more I do that, the better. The less I do that, and go to the gym. Going to the gym is vital for my self-esteem and my mental health. There's no doubt about that. Linda said, I just feel the damage is already done and just want to live out the rest of my days without pain. Okay, Linda, girl. The bladder can heal. Healing is always happening. Healing never turns off. You should not assume that you in any way have permanent damage. If you have an injured bladder wall, I can promise you right now, your bladder's trying to fix it. The challenge is that something is provoking your bladder every day. And it could, like when we started this meeting, could have been ketamine, could be coffee, could be the medication. Augmentin is an antibiotic that's really well known for irritating the bladder. When we stop irritating the bladder, guess what? The bladder heals. That healing process is not broken. It is not turned off. We just have to be a little bit more of a detective to try to understand why your bladder is so vulnerable. So concept number one is you've got estrogen atrophy. So the biggest difference is 25 years ago, you probably had a lot of estrogen and your bladder was stronger. But once you start losing estrogen, you start losing that protective coating of your bladder wall, which means your bladder's ability to defend itself from that medication is now compromised. And so we could say, okay, well, if you're of a certain, and I can't see your face from your profile picture, except I do think you might have gray hair. So, would using topical estrogen to rebuild your mucosal layer make it easier for your bladder to handle the medicine? Possibly. Would doing something that coats your bladder and gives your bladder a little bit of extra protection make it easier for your bladder to tolerate the medication? Yeah, possibly. You could do something like Bladder Builder or Bladder Rest or Cystomand. A chondroitin-based supplement might coat your bladder a little bit more. If we're stuck with the medication that's irritating it, then let's just try to protect that bladder wall a little bit more. You could potentially do rescue installations, heparin, to get some coating in there. But in the end, figuring out what the irritant is and letting that irritant go is reasonable. Linda said, cardiologist has let you start the vaginal estrogen. Okay. And sometimes they don't want you to do vaginal estrogen, especially if there's a risk of blood clots. So, I wish that we had a really easy answer, or just go from A to B or B to C. But in the end, we are a snowflake. We're all slightly different from each other, and finding what our bodies tolerate is challenging. And it's good. The B12 has you feeling better. That's fantastic. That's good. So you're doing good, honey. But it's okay to ask more questions. All right, here. Hold on a sec. Oh, you guys have been busy over here on YouTube. Crystal said, how am I looking up this stuff on Mayo Clinic? Go to their website, mayoclinic.com. Crystal says, have you heard good things about InterStim for overactive bladder and pelvic pain? The answer is no. We have a very big section on InterStim on our website at icnetwork.org. A lot of doctors like to say, hey, let's try InterStim because it's a nice moneymaker for them. But in the end, we need to know what your phenotype is to make sure you have the right treatment for your specific case of IC. InterStim used to be widely used. Now it has a very narrow place in the IC treatment program, and it has a lot of well-known side effects, including, there are thousands of adverse events filed with InterStim, a lot of post-op infections, MRSA infections, and including some fatalities have been reported. So InterStim you would not consider something like InterStim until you've done a lot of other things first, and you got to have your eyes wide open about what it does and what it does not do. Crystal said, I've tried some changes in your diet already. Good. But in the end, we need to know what your phenotype is. You need to know what your phenotype is. On our YouTube channel, we have our master class on IC. It's called the IC 101 Master Class. Would you watch episode 4? Watch episode 4 on phenotyping, and that will help us have a better understanding of what underlying causation is, rather than the assumption that you just have an incurable bladder disease, because we now know that's not true for most of us. Sarah says, what role does the nervous system play in neuroplasticity? I'm 8 years. I see hell, run out of hope, and I want it all to end. My life has been destroyed. Sarah, honey, number one, a big, giant hug. You are not alone in this at all. There is always hope. So your question is such an important question. The nervous system can play a significant role in your IC because it's nerves that transmit the symptoms of frequency urgency. It's nerves that transmit pain. And so when somebody has persistent frequency urgency, we're always going to ask, okay, what's going on with the alpha afferent nerve in the bladder wall? That something is poking and prodding that nerve and giving that patient that symptom of frequency urgency. Or if somebody has pain, we're going to ask, okay, what's wrong with the C fiber nerve in the bladder? Because that's a nerve that causes pain in the bladder. So for many IC patients, there is an original injury. There is an original trauma to tissue. They might have a muscle injury with very, very tight muscles, and those muscles are squeezing nerves. They're squeezing blood supply. Nerves need good blood supply to be healthy. If they don't, every nerve fiber has a blood vessel that feeds that nerve. So it's not just a nerve that's going through, that in that nerve bundle, there's also a little bit of blood supply. So let me see. There's a really good picture in here. Hold on a sec. So if you have really tight muscles, that would affect your nervous system. So that's why we've got to get the muscles healthy again. Let's see. Here's a picture right here. Let's see. Hold on a sec. I want to see if I can get this in here. So here is a nerve fiber. And that it's not just one nerve. There's a bunch of nerves that are in that bundle. And you can see that there's a lot of blood vessels on the outside. Okay? And these blood vessels nourish and help these nerves function right here. Now, some patients have, like one of our members, she had a really significant nerve injury where a nerve, she'd been in a horseback riding accident and a nerve was compressed. And when they finally went in surgically, this is what they found. Her round nerve was now flattened. Okay, but they were able to surgically release the restriction to get that nerve back into its proper position and structure. So, and then of course we have the role of neuroplasticity. So in our phenotyping system, one of our phenotypes is widespread pain. So these are patients who have IC, IBS, vulvodynia, TMJ, migraines, etc., characterized by having very sensitive skin or a wicked sense of smell. Can you smell things that other people can't smell, and the smells drive you crazy? Okay, that's the widespread pain phenotype. That's also one of my phenotypes. I'm in this group too. And so this is called a central nervous system maladaptation or central nervous system injury. What the research shows is that for 80% of the patients who develop this, there is a physical injury. And for the other 20%, it's a history of abuse or bullying. So when we study the central nervous system of patients who have widespread pain, this is what we find. A brain that is living in fight or flight. The 24 hours a day, 7 days a week, that brain is behaving as if that patient's life is at stake. Normally, fight or flight is short term. Fight or flight is meant, it goes back to the days of saber-toothed tigers. Man, when we were cave people, if we saw a saber-toothed tiger walking down the valley, believe me, we went into fight or flight. We froze or we moved or we hid to hide from the predator. This is how the human body keeps us safe. Fight or flight is an important survival process. And so now we're watching the saber-toothed tiger watch up the valley, and we're up on the hill, and we're not going to move a damn thing because we don't want to catch the attention of the saber-tooth tiger. And the tiger moves on its way, goes up the hill, over, it is gone. At that point in time, fight or flight is supposed to turn off. The parasympathetic nervous system retakes control of the brain, relaxes your heart rate, relaxes your blood pressure, relaxes your muscles. There's no reason for us to be in fight or flight. So fight or flight is a short-term process. But in patients with widespread pain, we're stuck in the on position. It takes 14 days of pain to put the brain into a constant state of fight or flight. It takes 21 days of bullying for the brain to put into a constant state of fight or flight. So what happened to me is I grew up in a neighborhood with a kid who became a rapist and murderer. And I did not leave my home without fear for a decade. I was in fight or flight every time I went to school and afterwards. And the year I went away to college, he raped and murdered my neighbor. So think about what that did to my nervous system. I became incredibly hypervigilant, and I still live with that today. Granted, I've had a lot of therapy and I know what to do about it now, but trauma is trauma. There can be physical trauma and there can be emotional trauma and abuse and things like that. And the most common theme in my office actually is growing up with an alcoholic parent. Every week I talk to children of alcoholics. Every damn week. I am not lying. And if you if you had a childhood where there was fear in that home, whether there was abuse in that home or drinking or drug use in that home, this is how a child's brain tries to save that child. It becomes very hypervigilant. The child doesn't understand what's going on. We didn't understand what was going on, but that central nervous system, that brainstem had one job: to save that child's life. So that child became very, very, very hypervigilant. That child lived in a constant state of fight or flight for much of their childhood. And the problem is even after you get older and you're now out of that house and that alcoholic parent has died, the brain becomes habituated into fight or flight. This is what it learned. And so therapeutically, our goal now is to turn fight or flight off. And we can do that. So I was attacked in 4th grade. Okay. I 100% attacked in 4th grade. I was attacked many times in my school year, especially elementary school and junior high, but mostly elementary school. And I can still remember how difficult it was because he hurt a lot of people. He hurt a lot of kids. And he raped and murdered my neighbor. So, he's in prison. But I was a favorite target. And I can guarantee you, if I'd been here that day, it would have been me and not her. He went after the redheaded girl. And my self-identity is a little redheaded girl running for her life. I'm still that little redheaded girl today, 100%. And I remember feeling so angry at my friends who would not walk with me because that's when he attacked and they were trying to save their life. And that's one of the reasons why I have trouble. I have a small core group of friends, but I'm not a real social girl because I got burned badly by people who wouldn't help me. It is what it is. So anyway, I did not understand the role that trauma played in my long-term health. I did not understand the anxiety. I did not understand the connection between the IC and the IBS and the vulvodynia and the TMJ and the migraines, all of which I had in my 20s. And yeah, my muscles were effed. My muscles were in horrific shape from that original injury, but my nervous system was in horrific shape too. And I used to have a lot of panic attacks, especially going to the doctor. I literally, and guys, I have a master's degree in psychology. I went into psychology to try to understand what was happening to my brain. And I was a straight A student. Believe me, I was a good student. And yet I couldn't stop my panic attacks. And finally, as I was walking around in the backyard crying before another doctor's appointment, I just went, oh my God, I'm so sick of this. Clearly, I'm missing something. And I signed up for an anxiety management class that completely changed my life. And of course, I had an anxiety attack going to the class because it was a hospital and I didn't like going to hospital. Ironically, I feel very safe at hospitals now, but back then I didn't. Okay. The first revelation happened in the first 5 minutes when we just met other patients. Because I think I took the class when I was 35. Okay. 35. I've been having panic attacks since I was a teenager. When I met other patients for the first time, it became really crystal clear to me that we were all perfectly normal people who had had something bad happen to us. And that immediately took all the shame away. All the shame I felt, all the blame I felt was like, oh, wait, that happened to you too? And that happened to you? And that happened to you? And everybody in that class had been through trauma. And I think prior to that, I just thought that I was like a walking, talking poster child for being effed up. And I really honestly felt that it was kind of my fault. And I kind of felt like I was just damaged goods and unworthy. I mean, I did. That's where my self-esteem was, dealing with all this anxiety. I just didn't understand it at all until I met other patients. And it was like, oh my God, that happened to me too. And then the instructor, the course was created by an orthopedic surgeon who had anxiety disorder. And the first thing they said is, how many of you say no to every single invitation? Hey, Jill, you want to go? No. You want to go to the? No. No. I had turned down every damn invitation I received from like the age of 15 to the age of 35. And I never knew why. Like before they could even finish the invitation, my mouth popped, no, I'm sorry, I can't do that. And the instructor goes, do you know what that is? And like, so he goes like, how many of you say no to every invitation? Everybody raised their hand. Everybody. And we're like, oh my God, you too? You too? Me too. He goes, do you know what that is? And we're like, no. He goes, that's guarding. That's your brain trying to keep you safe. It's called that's called the guarding reflex. It doesn't want you to go anywhere because something can happen. It's keeping you safe and at home. Now, it's different for somebody who was abused at home. Then they respond in a different way. They might say yes to every invitation to get away. I, on the other hand, said no to every invitation to stay home because I felt safe at home. Well, that was freaking mind-blowing. It's like, oh my God, because I literally wanted to go and accept all of those invitations. I lost so many friends because I said no to everything. And I never understood it. Hi, Peggy. So then he goes, and how many of you are really sensitive? You got sensitive skin, wicked sense of smell. How many of you are sensitive? We all look at each other. Oh yeah, I'm sensitive to everything. Medications, everything. We all were. And he goes, well, you know what that's from? And we're like, no. He goes, well, that means that your central nervous system has been in fight or flight. That's what it does. It gets more sensitive. Like, oh, okay. Now we're making more sense. And he said, how many of you are super chemically sensitive? Man, you don't like taking meds or anything because you're really prone to side effects. We all raise our hands, everybody. You too? You too? I thought it was only me. He goes, well, yeah, that's a sensitive nervous system. That's from trauma. And he said, you know how you're sensitive to chemicals on the outside? You're also sensitive to the chemicals that your body makes. And he said, right now, every single one of you in this class is overdosing on adrenaline. Peggy says, my husband says I can smell a fly fart. True. I have found more gas leaks. I've been offered a job by my gas company because I have a wicked sense of smell. I think I've found 4 gas leaks in the last 10 years. They're stunned when I find them, and they're legit gas leaks. So anyway, not only are you sensitive to chemicals on the outside, you are super sensitive to chemicals on the inside. Right now, every single one of you is overdosing on adrenaline. You have got so much adrenaline flowing through your body now. That's what's driving it all. That's what's driving the anxiety. That's what's driving the panic attacks. That's what's driving the racing heart. That's what's driving the nausea. Whatever symptom you're having, that's just adrenaline. Too much adrenaline. And he said the secret to controlling anxiety, controlling all of this, is we got to get rid of the adrenaline, because it's the adrenaline that's keeping your nervous system hyped up. So we're like, okay, how do we do that? He goes, it's easy. Oxygen. Oxygen turns off adrenaline. And we're like, okay, tell us more. And he said the fundamental challenge with trauma, with fight or flight, is that your brainstem has one job: to keep you safe. There's no cognition happening in fight or flight. Your brainstem just pays attention to what do you see, what do you hear, what do you smell, what do you taste, and what do you touch. And the moment it senses a threat, man, you go right into fight or flight. But as we get older, we get a little bit smarter, and we like, oh, maybe it's not that bad. And so we start to ignore it a little bit more. And that's when your brainstem goes, well, maybe we just need to catastrophize a little bit. So it's not, hey, Jill, you want to go to a movie? No, I'll have to get up and go to the bathroom. Well, when you're catastrophizing thought is, no, I'll have a horrific flare and I'll be in pain for 2 weeks and I'll ruin it for everybody. You know, that's catastrophizing. It's not just it's making it, exaggerating what can happen. And so if you've been in fight or flight for a period of time, you start to catastrophize. And that's why we ask about that in phenotyping. Do you find yourself struggling with anxiety and catastrophic thinking? Okay, not your fault, not mental illness. It's a brain that's been traumatized. It's a central nervous system that's been through something. Okay, so every time you have a catastrophic thought, a scary thought, you get a jolt of adrenaline because you trigger your brain back into fight or flight. And the problem is you don't just have one a day, you have 100 a day. That's 100 shots of adrenaline every single day. That constant negative, scary thoughts keeps you amped up. So he said the secret to all of this is to stop the negative thoughts, to stop the adrenaline. And we're like, okay, how do we do that? He taught us a 3-step technique that I use to this day. That whenever you have a negative thought, the first thing you do is you just visualize a stop sign. Just stop. I'm sick of it. I don't want to hear it. Stop. Then you take a single deep breath in for 3 and out for 3. And that oxygen has now rendered that adrenaline from that negative thought chemically neutral. It's done. It's over. It will not build up in your system. It is done. So stop sign. So negative thought, stop sign, deep breath. And then you just have to remind yourself it's a thought. It doesn't have any power. It's just your brain guarding you. What I tend to say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow's going to be one of the best days ever. It's just a thought. It's just guarding. It has no power in your life. Okay, stop sign, deep breath, minimize the thought. And he said, okay, listen, for this first week, all we want to do is bring down the adrenaline levels in your bloodstream. So what I want you to do is go home and for the next week, listen to your thoughts and do it. Every single time you have a negative thought, do it. Stop sign, deep breath, minimize the thought. The chemistry made perfect sense to me. I'm like, all right, I'm in. And I had my first negative thought walking out of the room, like, oh my God, this is so stupid. How could this ever work? But I did it. Stop sign, deep breath, minimize the thought. Like, Jill, you don't know if it's not going to work because you haven't even tried it. Give it a shot. Okay. That first day, I did it at least 100 times, at least. And I was stunned. I had gotten so used to the scary stuff that I just kind of tuned it out, but it was there. It was constantly there. This will happen, that'll happen, this will happen, that'll happen. Scary thought, scary thought, scary thought, like all the time. And what really shocked me is how many of them were about me. Oh my God, Jill, what's wrong with you? You're such an embarrassment. Only half of those thoughts were really, really brutal thoughts about my self-esteem because I just didn't understand what was going on. So the first day I did it at least 100 times. Second day I did it about 50 times. Third day I did it about 20 times because guess what? Oxygen turns off adrenaline. So we're slowly bringing the adrenaline levels down, my friends. 5 days later, I only had to do it once. And for the first time since 4th grade when I was attacked, I was finally out of fight or flight. It was shocking how good I felt, how much better I felt. And so the enemy for me now personally is negative thoughts. I know that you cannot allow yourself to have a string of negative thoughts because I don't need 5 shots of adrenaline in my bloodstream. So I usually have one a day. Usually it's about an earthquake. Don't ask me why. I have no idea why. If I have 2 negative thoughts in a row, I always do it. It's very rare that I have 3. If I do it twice. Because I know that it's the adrenaline that's driving all of that. And so that class changed my life. And I've gotten through cancer, I've gotten through surgeries, I've gotten through deaths. And that's what I do. I'm driving myself to the emergency room at 2 a.m, stop sign, deep breath, minimize thought. So Sarah, you know, we have phenotypes. We need to know what your phenotype is. Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, widespread pain. That's start number 1. If you're in the widespread pain group, we know how to treat that now. We know how to do that. And we now have some supplements that calm nerves down. Peora, where is it? So we've got Peora and we've got Pea Leaf. These are palmitoyl ethanolamide supplements that act to physically calm irritated nerves down. The IC study was phenomenal that 87% of IC patients who used PEA reported a significant progressive reduction in pain. A lot of people ask me what I do. Well, that's what I take because I'm very, very heavily invested in keeping my nervous system as calm as I can. And it's been really wonderful for me. So, call me tomorrow. I'd be happy to help go through these phenotypes with you to see if we can identify underlying causation for you a little bit more clearly, send you back to the doctor with a new set of questions, potentially some new treatments. I'm really glad that you're working on the trauma. I'm working on the trauma too. Sarah says it came out of nowhere with no history. It can be anything. It could be a physical injury. It could be having an abusive boss. I mean, I've worked with patients who've developed this when they went to work for an employer who had a very, very abusive boss. It can happen in childhood. It can happen in adult. But the blessing here is we know what it is and we can work on that. Max said, my IC started overnight in the same week as catching COVID. Does that give any clues? Yes, it does, Max. That means you have COVID cystitis. COVID cystitis is real. COVID cystitis was first identified within the first couple weeks or 6 weeks of the pandemic. It was first discovered in Germany. They published it. Then the American researchers in Michigan confirmed it in their patients. It's called a de novo onset of urinary symptoms. What that means is that patient had no prior history of bladder issues until they got COVID. We believe what's happening, and they believe what's happening, is that cytokine storm that normally happens in the lungs is also happening in the urinary tract, and that's creating a lot of inflammation in the urinary tract. COVID cystitis generally runs out and calms down over time. I see patients who have gotten COVID. 75% of IC patients who have gotten COVID flared from it. 25% have had very, very severe flares from it, but it tends to have an end date. It can take many months, but it does slowly calm down over time. We have a website, covidcystitis.org. You can go read to learn more about that. Crystal, so if you could, Crystal says, how do we get the supplements? And I would like to know my phenotype. On the IC Network website, icnetwork.org, in the menu bar is the IC 101 Masterclass. It's a video series. It's all free. I need you to watch the first 4 at a minimum episodes of the masterclass. Episode 4 talks about phenotypes. You've got a lot you've got to learn about here because, IC is complex. For some people, it's injury driven. For others, it's autoimmune. For some people, it's chemical injury of the bladder. There's a lot of different things. And once you get phenotyped, you'll have a much better idea about what the right treatment is for your unique case. So we're not casting big, broad brushes anymore, saying everybody has this or everybody had that. And the whole people who are saying it's embedded infection can kiss my ass. It's just, anybody who says everybody has embedded infection, that's so incredibly irresponsible. And it shows they do not know IC. Because if you met other patients, you would see the many different causes. Embedded infection doesn't explain why patients going through chemotherapy get IC. And that's because the chemicals from the chemo damage their bladder. It doesn't explain why the patient who develops symptoms after falling down the stairs develop IC. That's because they have a neuromuscular problem. It doesn't explain why patients who get older and have estrogen atrophy get IC symptoms. That's not embedded infection. The embedded infection people are just collectively driving the urology community kind of bonkers because they're so freaking self-righteous about it. But I can tell you, as somebody who's run a support group for 30 years and who's worked directly with thousands and thousands of patients, I can count on one hand the number of patients who have embedded infection. Now, listen, it's possible. I'm not saying it's not possible. That's why we have next generation DNA urine testing. You can pay $200, $300, have your urine test. Let's see what that finds. But for anybody out there to tell everybody y'all have embedded infection and you should all be on long-term antibiotic, they are full of it. It's not true. And if you were to come to an IC conference and to meet other patients, you would see that very, very quickly. They've done a lot of harm, and I've been dealing with them for 30 freaking years. I can give you the whole history of how it started. Sarah said, I was living with the belief it was embedded infection, and that has really ruined my belief I would never heal. And I'm just going to tell you right now, healing is not only possible when we find and identify your phenotype and give you the right treatments. Like me, listen, I went from eating just a couple of foods and having pain so severe, I was having very, very dark thoughts. And I had a doctor say to me, "You will forever be a burden on your family. This is your life. You will always live with pain." That was in 1993 when I was 33. And he said that to my face. And I just went, wait a second. Wait a minute. How dare you say that to me? I will prove you wrong, you son of a bitch. That's exactly what I said to him in the emergency room at a local hospital here. And I went home and I started studying. And the IC network is a product of 30 years of study, which is why we're rated #1 by the University of London and Harvard Medical School. Because I do research too. I have a lot of training here. So I lived with the perception that I had an incurable bladder disease for decades until the pelvic floor research came out. I never understood why my bladder looked healthy. Whenever they looked at my bladder, it was a baby bladder. It was pristine. And yet I was peeing every 15 minutes. And I was completely sleep deprived. And then the research about the pelvic floor came out, and I went, oh, well, let me go get that checked. My pelvic floor was as hard as concrete. And that goes back to an old injury. Once I started doing pelvic floor physical therapy, I mean, the bladder instills didn't do a damn thing for me. The antidepressants didn't do anything for me. Bladder treatments did nothing for me, ever. DMSO, ever. Physical therapy is what healed me. And I don't live with pain every day anymore. The only pain I have right now is just from my double mastectomy. I rarely have bladder pain. Now, I will say I occasionally have pelvic floor pain if I sit too long. Definitely. You know, my pelvic floor is I'm older now. I'm older. Sarah, that's why I'm so frustrated with them, is I don't think they understand the harm that they're doing. To tell patients they have an embedded infection and that they need to be on antibiotics for years or the rest of their life without encouraging them to get properly phenotyped, without encouraging them to learn about IC more. You know, they have a very black and white perspective. And yet there are many patients who have tried it and they've never gotten better. And then when they find us and it's like, well, yeah, I did the whole antibiotics for 2 years, did nothing for me. And then we start talking, it's like, okay, when do you think your IC started? It's like, well, you know, I fell down the stairs. That's when it started. Okay, so you do realize that wasn't infection. That actually was injury. So like, oh, makes sense. Makes sense. Sarah says she lost her 20-year relationship over it. Well, but there's hope, honey. There's hope. You should call, I mean, watch the video, IC 101 Masterclass, and just learn a little bit more about it. And then after you watch the video, you know, especially episode 4, call me and let's talk. Allison said, how long do you have to have physical therapy to get consistent relief? It depends upon what the problem is, honey. The question the most important question you ask your physical therapist is, am I responding to physical therapy? Are my muscles relaxing consistently? Because if your muscles are always staying tight, no matter what they do, then we have to figure that out, because that usually means that we're dealing with a hip problem, an SI problem, a knee problem, or in many cases, a foot problem. So when muscles continue to stay tight, that's when we have to start looking at bones. And so that's what you have to ask a physical therapist is, are my muscles responding or are they always tight? If they're always tight, then that's when we want to look at your hip. Like my muscles on my left side are almost always tight because my SI joint is hyperflexible. As Allison said here, she has hypermobile Ehlers-Danlos syndrome, and I personally have a very hypermobile SI joint on my left side. Allison says, so she asks, what coats the bladder the best to rebuild the barrier? Nothing that you can put in your bladder will rebuild the barrier. Only your bladder can rebuild the barrier. Our job is to protect the bladder while it's trying to heal. And so that's going to be a chondroitin-based supplement. So Bladder Builder is, in my opinion, the best supplement on the market. Bladder Rest is a kind of simpler, clean, pristine formula for patients who are sensitive. Cystoprotect or Cystomend are the top 4 chondroitin-based supplements. The reason why I say chondroitin is because chondroitin is a building block of the bladder wall. It's essential to the superficial integrity of the bladder wall, and it has a very high bioavailability at about 25%, so we know enough of it gets to the bladder to actually do something. It is not aloe. All right. Well, listen, we've been going for almost 3 hours now. See, the only reason I could do this is because I went to the gym this morning and I worked hard at the gym, and that really helps my state of mind. Diane said she would say yes to everything to get you out of the house when you were younger because your dad was an alcoholic. Now I say no sometimes to going out because of the bladder stuff. Yeah. You're welcome, my friends. You're welcome. Sarah says, can you call from the UK? Absolutely. We can Zoom. Our challenge, let's see, you're right now, what is it, like 1 in the morning for you right now? 1 or 2 in the morning, so you are up late. So pop me an email. Yes, Crystal, the calls are free. You can call our 800 number if you're in America. So my direct line here, I'm giving it to you. That's a direct line. The 800 line for Americans, 800-928-7496. There you go. And my email address is icnetwork@mac.com. So, Sarah, email me tomorrow. And then I will try to email you back and we can just try to Zoom. Okay. But just understand that Mondays used to be my day off because I work on Sundays. And so I'm not necessarily all together on Monday, especially in the morning. So I might have to rest my voice because talking for so long tends to tweak my voice pretty badly. So Tuesday is always better than Monday, but I'm open to trying it on Monday too. Okay. All right, my friends. Well, listen, I hope that I was able to help you a little bit. If you find these meetings helpful, please come on over to the IC Network and sign up to get our free newsletter. If you want to support my work and our work, sign up. You can become a member and you would get our magazine, the IC Optimist. We've been doing this for how many years now? I think this is our 23rd year. How long have we been doing this? Yeah, we're starting our 24th year. This is where we do our best work, is in our magazine. And you can get it for $25 a year. If you want it mailed to you, it's $50. But anyway, because paper's so expensive. It would be great if you could become a member or just going over to the IC Network into our shop and buy something that helps pay the bills too. Times are really hard for everybody. I was supposed to get part of a CDC grant this year that would have been incredibly helpful for expanding the work that we're doing. And like all the other grants, it was canceled. So, had to make a lot of cutbacks to compensate for losing them. So any support you can give us would be great. All right, my friends, I truly wish you well. And remember, no meeting next week. We have to celebrate my sister's birthday. But the week after that, I should be back. All right. All right. Good evening. Sleep well. You are not alone, my friend. Not your fault. Listen, one last thing. There's one thing you remember from tonight. It's me telling you and looking you right in the eye. This is not your fault. You have done nothing wrong. I don't want you carrying any shame or any blame about your health right now. You're hurt. Just like somebody who's been hit by a car, you would love all over them and help them. You're no different. You deserve that love and kindness too. Stop beating yourself up. This is not all in your head. Carry hope in your heart. Okay? All right. Bye, YouTube.